I'm just
Wonderful.
checking in.
Wonderful. Wonderful. All right. So, good evening, everyone. Good evening to all the prestigious faculty members who are present on the faculty link and the doctors who are attending us live on the registered link. Good evening from the ISAR as well as good evening from UNS. This is Pallavi More reporting from UNS to you this evening, where some parts of India are filled with very lively monsoon. I was just speaking about this to our leading faculty members present over the call as well. This evening is a special evening for us because another set of extremely scientific, highly scientific topics are going to be discussed and avidly presented by our coveted speakers, and our chairpersons will be moderating the session. As UNS, I represent the CoQ brand, the CoQ flagship of India. UNS, as in Universal Nutriscience, as a legacy product, introduced coenzyme Q10 for the first time in India. And India knows coenzyme Q10 only because of UNS. UNS is proud to present its entire range of CoQ and to be associated with you. And we would love to hold an opportunity with each one of the COVID doctor and expert who is present on this call to present this brand to uplift the outcomes of infertility specialists and fertility boosting. With this, I will now hand over to my medical team, which is, of course, under the leadership of Dr. Manish Garg, who is present on the call, and one of his team members, my medical manager, Dr. Shruti Patwal, to take the lead and the conversation ahead. And of course, joining me is my marketing team. Mr. Rishikesh Chaudhary is also present on the front, who is leading this show for us from UNS. So here's Dr. Shruti, handing over to you. Thank you.
Thank you so much, Pallavi ma'am. Good evening to all the esteemed faculty members for joining us today. And we would like to welcome you to the third series of the Fertilogix. And for this time, the theme is Cradling Hope, Obstetric Nuances in ART-Enabled Pregnancies. And this wouldn't have been possible without our program director, Dr. Archana Basir ma'am, who's also the chairperson for MPSR, and obviously without the support and guidance of Dr. Kalyani ma'am, Dr. Rutri ma'am, and Dr. Shruti ma'am. Dr. Kalyani ma'am is the clinical director and senior consultant for reproductive medicine at Nova IVF, Indore and Ratlam. She has a rich experience of more than 17 years, has several awards and recognitions to her name, has been associated with different affiliations as well as contributed academically to various book chapters and various index journal articles. Dr. Rudri ma'am is also associated with Nova IVF at Ratlam, Indore. She also has several awards and recognitions to her name, including gold medals in MS. She is also associated with Foxy, ISHRE, SRM, and so on. With this, I would like to hand over to Dr. Rudri ma'am and Dr. Kalyani.
Thank you so much, Shruti. So, good evening, everyone. And it's my immense pleasure to welcome everyone present here to the third part of this Fertilogix webinar series, which is a joint collaboration between UNS, MP chapter of ISAR, in association with Bangalore and Gujarat chapter. I'm Dr. Rudri Agrawal, and I extend a very warm welcome to all of you. And I would also like to congratulate every joiners for joining us today for an academic session filled with so much of knowledge. And I express my heartfelt gratitude to our esteemed faculties who have graciously accepted our invitation despite their busy schedules. So before we begin, let's invoke the blessings of Goddess Saraswati. May this webinar be enlightening and fruitful. So let's proceed with the lamp lighting ceremony. May we have the video, please?
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती जाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Thank you so much, Shruti. Going forward, I request Dr. Kalyani Srimali ma'am to take the session further and kindly welcome the coordinator and director of this whole series, Dr. Archana Basir ma'am, for all of us. Over to you, Kalyani ma'am. May we have Kalyani ma'am with us? Okay, Shruti, can you display the CVs, please?
Yes, I'll display this.
Yes. Okay, so I think there is a technical glitch probably. Kalyani ma'am, mic is not working. So let me begin the program by introducing the coordinator, the director of this whole program. None other than Dr. Archana Basir ma'am herself. And Dr. Archana Basir ma'am is MD DNB and she is director of Dr. Archana Basir ma'am is the director at Akash Hospital Indore and she has been vice president of Foxy in 2020, has been an organizing secretary of AICOG 2021 Indore, and ma'am has holding the record of operating the largest uterine tumor. Ma'am has been holding the past positions of chairperson Foxy committee, organizing secretary of ISAR 2016 and managing committee member of ISAR 2018, 2020, IAGE and ICOG. We welcome you, ma'am, and I would request you to kindly welcome our chief guest, Dr. Kamini Rao, ma'am, and our guest of honor, Dr. Mangla Devi, ma'am, for all of us. Dr. Archana, ma'am. Shruti, are you able to hear me?
Yes, ma'am.
Ma'am, you're audible.
Yeah. So, can you request Archana, ma'am, to kindly take the session further?
Yes, Dr. Archana ma'am, can you please
I
start?
think with some audio issues.
Yeah,
Or
I think
not
I
connected.
manage. Yeah,
Okay, just give me a minute.
sure, no.
So, I think Archana, ma'am, is now able to join us.
Can you hear me? Hello.
Yes, ma'am, you are quite
No,
audible.
Rutri, I can see. Can you hear me?
Yes, ma'am, you are
Okay,
quite
okay.
audible.
I think my this because of the heavy rains, this thing is becoming very unstable. So at the outset, let me welcome all the guests and all faculty, and I'm really happy that I have met many of our faculty today in actual conference. Dr. Mangala, others I know, like Dr. Kamini. Is Dr. Kamini Rao here? As Hello.
Ma'am, no, her name is, no, she's not logged in, ma'am, yet.
I'm really sorry, Rudri. My thing is becoming very unstable. Is Kamini madam here?
Ma'am, she has not joined so far.
Hello. Okay, so we wait for madam, and when she joins, we know that Dr. Kamini Rao is Padma Shri, and she is past president of Foxy, and many awards to her and many publications. And so I'll reintroduce madam when she comes. Let me introduce our guest of honor, Dr. Mangala Devi. She's here, Dr. Mangala. Can I have the CV of? Hello.
Yes, ma'am, you are audible, ma'am.
I just you have to keep reminding me, Rudri. I'm
Yes, ma'am.
really
Yes,
sorry
ma'am.
today.
Yes.
So,
Yes.
Dr. Mangala, I have recently met. She's a young president of Bangalore Society of Obstetrics and Gynae, very dynamic person, and she is MBA also from BITS Pilani. Apart from her MBBS and MS Obs and Gynae, she has been treasurer of IFS Karnataka and speaker and chairperson and judge at several local and state conference. So I invite you, Dr. Mangala, for your advices to us on this webinar, where we will be talking about hormones in IVF pregnancy, how much, how long, and surrogacy. And we have a very interesting panel lined up where moderator is Dr. Mahesh. And hello.
Yes,
So
ma'am, you are
Dr.
audible, ma'am.
Mangala, Dr. Mangala, over to you.
Dr. Archana ma'am, we request you to
Ma'am, let
please
me.
switch off your video, sorry, so you can
Okay,
save some
so
bandwidth, so your network
okay,
will not get fluctuated.
okay. Thank
Thank
you
you.
so much for advising. Yep.
Good evening, everyone. Thank you, Dr. Archana ma'am, for inviting me over for this webinar. I'm looking forward to a lot of informative sessions and a lot of input from all the speakers and panelists as well. Thank you, ma'am.
Thank you, thank you, Dr. Mangla, and please stay with us for the session, and we look forward for interaction and your inputs on the talks and the.
Sure, ma'am. Sure,
Yeah.
definitely.
So, Dr. Rudri, if Dr. Kamini has not joined, we'll
Yes, ma'am.
introduce her
Yes,
later,
ma'am.
so we can get on
Yes,
with the
ma'am.
scientific program. Yeah.
Yes, ma'am. So, for going forward for the scientific session, I would request Dr. Sabine sir to join us as chairperson. May we have the CVs, please? Dr. Sabine sir. So, sir is the owner of Sabine Hospital and Research Center and Child Hospital, and he is a fertility specialist and laparoscopic surgeon with significant growth strategy. And sir is an active member of Aspire Asia Pacific Initiative on Reproduction and an active member of ASHRAE. And sir has, to his credit, there are multiple publications and awards. So we welcome you, sir, as one of the esteemed chairperson with us today. Now, I would like to welcome Dr. Anuradha Kar, ma'am, as our next esteemed chairperson. Ma'am is a director at Nurture Fertility Center, Bangalore, and currently practicing infertility and infertility-related endoscopy at Bangalore. And to her credit, there are multiple publications, multiple awards, and she has several chapters in various also. We welcome you, ma'am. Next, we have Dr. Kanti Bansal, ma'am, as our esteemed chairperson. Ma'am is director at Safal Fertility Foundation, Ahmedabad, and she is a chief IVF expert at SNE IVF Center in Ahmedabad. Ma'am has published more than 30 scientific articles and more than 50 chapters in the medical book, and she has been a mentor to many ART specialists. We welcome you, ma'am. Now I request Dr. Archana Vasir, ma'am, to take the session further and start with her talk. May we have Dr. Archana Basir, ma'am? I think there is again a technical glitch at ma'am's end. I mean, just give me a few minutes to.
Ma'am has rejoined actually. Just 1 minute. I think she's joining you now. Dr. Archana ma'am.
I'm here.
Yes, ma'am.
Is ma'am able to join again?
Yes, ma'am has joined.
Hello.
Okay. Yes, ma'am, you are audible now.
Yeah, so let me share my screen and whatever. Otherwise, you can ask Dr. Naina to come before
Ma'am,
me.
your screen is
Might
not
settle
visible
this.
yet.
And because I'm just going to start.
Yes, ma'am, it is visible now.
With me. Is it visible now?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am.
It's visible.
Hello. So without, any this thing, let me begin with my talk. Hormonal support in IVF pregnancies. And we all know hormones and IVF go hand in hand. Precise hormone levels are vital for success of an IVF cycle, and too few or too many hormones can disrupt the delicate process, leading to undesired outcomes. And IVF is a complex process that relies heavily on the delicate balance of hormones in the body. Follicle stimulating hormone, we all know FSH, LH, and estrogen and progesterone. These are the hormones which are on the regular, this thing we get them tested, and we know that these are mandatory for an IVF cycle. FSH is responsible for follicle growth, LH triggers ovulation, and estrogen, as the follicle grows, it prepares the uterine lining for implantation and supports the healthy development of eggs. And progesterone, after ovulation, progesterone takes over and maintains the uterine lining, creating an ideal environment for embryo implantation in early pregnancies. We know that gonadotropin releasing hormone, agonist, antagonist, this helps control the timing of ovulation by preventing premature release of eggs, allowing for precise egg retrieval. Human chorionic gonadotropin is administered as a trigger shot to finalize egg maturation and induce ovulation before egg retrieval. Well, hormone support in ART is an ongoing challenge. We know that different hormones are used, as I have talked, but our hero remains the progesterone. And the biggest challenge we face is when to start progesterone. There are lots of debates and lot of studies and lot of variations amongst the clinics and amongst the researchers and among different reports what we read. So I'm going to talk when to start progesterone, which progesterone to be used, and how long to continue progesterone, and how to make a perfect blend in the cocktail. We know that luteal phase and gonadotropin stimulation, because there is a supraphysiological levels of estrogen and progesterone, leads to incomplete luteinization. The luteal phase in gonadotropin cycle is inadequate and varies with the degree of stimulation. So luteal phase in ART cycle, it get affected because of the gonadotropins. GnRH agonist and antagonist blocks tonic LH secretion. Luteolysis occurs when agonist is stopped, and all ART cycles require luteal phase support. That is the key thing. Now, what is the rationale for luteal phase support in ART? In ART, low progesterone environment is created by us by iatrogenic due to interventions. And GnRH analog, both agonist and antagonist, they suppress gonadotropin secretions. And once downregulated, pituitary functions does not resume until 2 to 3 weeks after the end of GnRH therapy. Then again, the rationale for luteal phase support in ART, because HCG administered for final oocyte administration, it suppresses LH production via a short loop feedback mechanism, and supraphysiological levels of steroids secreted by a high number of corpora lutea during early luteal phase directly inhibit LH release via negative feedback mechanism. Luteal phase LH levels found to be decreased in the HMG only cycles, and defective LH secretion might induce a luteal phase defect in stimulated cycle. So this is again a picture showing us rationale for luteal phase support in pregnancy. Progesterone supports endometrial growth. It improves blood flow and oxygen supply by increasing nitric oxide production. It keeps myometrium quiet by uterorelaxing effect and sustains survival of embryo by shifting immune system towards production of T helper response. How do you manage LPD? Their strategies include to luteal phase defect is progesterone, progesterone plus estrogen, and HCG in the luteal phase. We have progesterone supplementation. There are different routes of using the progesterone. Natural micronized progesterone can be administered via different routes, like oral route, capsule, sustained release tablets, by vaginal route, gel, capsule, effervescent tablets, intramuscular oil-based injection, intramuscular aqua-based injection, and subcutaneous aqua-based injections and rectal capsules can be used. Now, it's always like which route to be used. Among different routes of administration, there are no statistically significant difference between intramuscular progesterone and other routes, whether you use vaginal, oral, and rectal for IVF cycle, fresh and frozen embryo transfer cycle. There's no statistically significant difference in live birth rate between intramuscular versus oral and versus vaginal or rectal route. Progesterone supplementation route, if you see progesterone gel, progesterone effervescent tablet, and progesterone capsules. The advantage of using by vaginal route, there is a high uterine progesterone concentration with low peripheral serum values and uterine first pass effect where liver metabolization is absent. So that is very good thing for vaginal route, that liver bypass is there. So mechanism of uterine first pass effect because of giving by vaginal route, there is a counter current transfer of progesterone from vaginal veins to uterine arteries, direct diffusion of progesterone from vagina to uterus, and transport of progesterone from lymphatic and venous circulatory system, and transport through cervix intracervical aspiration. Progesterone luteal phase support after ovulation induction and intrauterine insemination and updated systemic review and meta-analysis. What does it say? To evaluate the effect of progesterone for luteal phase support after ovulation induction and intrauterine insemination, 11 randomized controlled trials were there and total number of patients were 2,842 and 4,065 cycles, and main outcome was live birth measure. So what they have found, intramuscular versus vaginal versus rectal progesterone, and it's a meta-analysis, the Cochrane database of systematic review of 2015. So this is what is the result, that there's no difference. That's a big rate. They have said there's no difference in whatever route you are giving. Now, micronized vaginal progesterone versus progesterone gel for luteal phase support. There are 5 randomized control trial, no difference in implantation rate or clinical pregnancy rate. So it is very confusing. Effectiveness of different routes of progesterone for luteal phase support, vaginal is effective, intramuscular oral, it is true, and vaginal route safer and more patient friendly than intramuscular or oral, lower side effect because of the vaginal route, and increased patient satisfaction, that is true. Now, we are also more using GnRH agonist also for luteal support. Administration of 0.1 milligram of GnRH agonist on day 6 after ovum become led to a significant improvement in live birth rate after ICSI compared with placebo. Luteal phase GnRH agonist administration increases luteal phase serum HCG, E2 and T4 concentration. What does the Cochrane review says? That they had a 94 women randomized control trial included, and progesterone versus placebo, no treatment, 8 randomized control trial, and higher rate of live birth or ongoing pregnancy there was in the progesterone group. Progesterone versus HCG regimes were also tried. Progesterone during luteal phase is associated with higher rates of live birth or ongoing pregnancy than placebo. That is what this review says. Now, the biggest question is, we all know, and there is a consensus that progesterone is needed for luteal phase support in all ART pregnancies. I think there is no two thoughts on that. Now, when to start luteal support? That is a very important question. Progesterone supplementation may be started on day after ovulatory HCG dose on day after oocyte retrieval or on day of embryo transfer. A prospective randomized trial in oocyte donation program, no difference in implantation, pregnancy, and ongoing pregnancy rates when progesterone was delayed until the day of fertilization. Luteal phase support now, next thing is for how long? Usually given till 8 weeks when the placenta takes over the function of producing hormones and up to the 12 weeks. But according to ASRM guidelines, there is no proven role in aiding progesterone or HCG for luteal phase support once a pregnancy has been established. Recent randomized control trial, no benefit after first ultrasound, use of supplemental progesterone in a non-ART cycle beyond the time of expected menses, 2 weeks after ovulation, no proven beneficial. I think we all will differ on this slide because everyone is having their own protocols and everyone is, as per their experience and as per their convictions, are using progesterone, and how long. Some are using for 8 weeks, some for 12 weeks, some for 24 weeks. So there is no one answer to this big question. Then what is the optimal dose of progesterone? There is no current consensus on minimal mid-luteal progesterone level required for adequate luteal phase in stimulated cycle. Optimal dose for high progesterone is not identified. Dose based on route of administration, vaginal route 200 milligram 3 times a day. In IVF, intramuscular, if you are giving, you use 50 milligram or 100 milligram based on the weight of the patient. Vaginal or intramuscular administration provides optimal endometrial receptivity. Oral route not recommended, greater chance of out of phase endometrium. Now, duration of progesterone exposure before transfer, absence of corpus luteum in especially the FET cycles and in the IVF cycle makes the duration of progesterone before transfer crucial to outcome of pregnancy, especially in FET cycles. And it is well recognized that inappropriate progesterone duration before transfer can result in an out of sync endometrium and embryo, leading to early pregnancy loss. Progesterone prior to blast transfer, there is no consensus has been reached on the optimal duration of progesterone administration before transferring a vitrified warm blastocyst. So, I mean, blastocysts have been transferred from 5 to 7 days of progesterone administration in different protocols nowadays. So, based on available evidence, it has been proposed that blastocysts be transferred at least on day P plus embryonic age in FET cycles, which is typically 1 day after. Then this is the role of estrogen. Is there any role of estrogen in IVF cycles? Yes, estradiol may be administered either as a fixed dose of 6 milligram or in step-up regime starting at 2 milligram and increasing to 6 milligram over 10 to 15 days. A large retrospective cohort study reported no difference in live birth rate between the fixed dose and step-up dose of estradiol transdermal supplementation. Some are using transdermal patches of estrogen, and they found that constant dose regime was associated with comparable live birth rate and obstetric outcomes, but with a lower spontaneous abortion rate than that observed in increasing regime. GnRH agonist, although unplanned spontaneous follicular growth and ovulation are rare conditions in HRT cycle, they occur without pituitary suppression using GnRH agonist with incidence ranging from 1.9%. So I think although suppressing the hypothalamus pituitary axis to avoid ovulation can be achieved by GnRH agonist administration prior to HRT cycles, without GnRH agonist co-treatment seems to be more patient friendly due to the reduction in cost and potential side effect associated with down regulation. So in conclusion, based on the available data, GnRH agonist HRT cannot improve pregnancy outcomes in general infertile individuals while increasing the cost and duration of therapy, and more randomized control trials are required to confirm its efficacy for recurrent implantation failure and PCOS patient. Now, is it important to do endocrine monitoring during IVF cycle? Monitoring during estrogen supplementation in FET in addition to checking the endometrial thickness via the ultrasonography prior to embryo transfer, the necessity of endocrine monitoring in artificial cycle remains again the controversial. So, I mean, there is a large retrospective cohort study that investigated the effect of serum estradiol levels before progesterone administration on FET outcomes, reported a statistically significant negative association between higher estradiol levels and both lower live birth rate and clinical pregnancy rate. So monitoring during luteal phase in FET, there's a we are monitoring, many centers are monitoring the progesterone level, low blood progesterone levels at 8.8 to 10.6 nanogram per ml when progesterone is supplemented through the vaginal route around the time of the frozen blastocyst transfer have been linked to the low live birth rate. The bottom plus progesterone threshold associated with pregnancy outcomes appear around 10 nanogram per ml in the mid-luteal phase of natural cycle. In contrast, the progesterone cutoff values reported for FET cycles using intramuscular progesterone are higher, reaching to 13.6 nanogram per ml or even 20 nanogram per ml. So, in conclusion of this, serum progesterone monitoring has an important role not only during implantation but also in pregnancy maintenance. And it is recommended to check progesterone level on or before embryo transfer day, but it is yet unclear if progesterone monitoring is essential at any other point. So, the take-home message is, like in controlled ovarian stimulation, luteal endocrinology and endometrium is complicated by possible effect of pituitary down regulation with GnRH analog, use of HCG or GnRH analog to trigger oocyte maturation, and endometrium is subject to altered endocrinological environment due to supraphysiological steroid level, which are responsible for impaired implantation. Luteal phase support is essential in all ART cycles and those non-ART ovulation induction cycle which use gonadotropin and GnRH analog. So thank you very much for patience hearing, and I'm really sorry for the technical glitches. And this is one strategy for hormone level optimization. You have to have a personalized treatment plans because every IVF or every patient is different. What other things you should do along with the hormone level optimization, nutritional support, stress reduction techniques, and emotional support. And thank you very much.
Thank you, ma'am, for such a wonderful and crisp talk. Now, I invite our chairpersons to kindly give your valuable inputs and conclude the sessions. Dr. Anuradha, ma'am. Dr. Sabain, sir.
Yeah, good evening, madam. It was a wonderful presentation. Right from the basics, we have explained everything in a very crisp and understandable manner with good pictures. Now, as you all know, infertility is a play of hormones. So the right dose at the right time and the right brand and the right molecule. That's the secret of infertility. So we have yet to find out where it is, where we are. We go by experience, and madam has given us a very good insight into the use of progesterones in pregnancy. Madam, you told me telling about use of GnRH analogs in luteal support. Can you just tell us how you are using it?
Actually, I don't have a great experience of using it, but I know people are using it in a low dose. Just as I said, Dr. Sabine, everybody is having their own protocols, right?
Yes. I have seen that.
Everyone has their different experiences. So I think there is a protocol for GnRH agonist use in the luteal phase support. Some people are using even the low doses of HCG also in luteal phase support.
Yes.
Yes, I agree with Dr. Archana. And first of all, Dr. Archana, hearty congratulations. As usually, you've been so, you've done the presentation so well. And of course, it's such a tricky subject. Why, how, when, how much, till when, that is very important. Especially in pregnancy, I think as because of this advent of assisted reproductive techniques, we are pumping in a lot of progesterone and helping the manufacturers and the pharma companies. That is that's okay. But then does it really harm the fetus in any way, such large amounts? And really till when, especially for the ART pregnancies, do we really continue till how long? Because once the placenta is formed, it produces enough progesterone. We all know that. And another thing I wanted to, it's, I don't know whether it may not be in this, your topic, but then these days people are giving a lot of injections also, progesterone injections. Even though when we started, there were oil-based injections, now we have the aqua-based injections, but these injections are even these aqua-based injections are very painful. So I think the other other forms of progesterone are good enough, the vaginal and also the dydrogesterone. And so what is your take on this?
Sorry, Kanti, can you just repeat?
Yeah, I was saying
Hello?
that, yeah, I'm going to repeat. See, we are pumping in a lot of progesterone, especially because of the ART advent. So now we are also giving, nowadays we're giving the aqueous, that's a water soluble progesterone. And earlier we were giving the oil based. Oil based were very, very painful, and sometimes abscess and all used to happen. But now we have the aqueous. But even with the aqueous injections, I've seen that patients really have a lot of pain. It's not that there's no pain. So do we really need to give these injectables? I have been very conservative in giving medications to my patients. So I just use the vaginal route. Vaginal route, I'm really very happy. Plus, also I give dydrogesterone. So what is your take on this?
Kanti, basically, I hope you can all hear me. I'm just trying to connect with other this device.
Yes.
Anuradha, can you answer the question for me?
Anuradha ma'am.
I think the net is not proper in some places, is it? Network?
Yes, ma'am. At Archana ma'am's end, there is some network issues there. So Archana ma'am is requesting Dr. Anuradha ma'am to discuss this question.
So,
Yeah, now I can,
there
I'm
is-
connected
there
with
is
other
no-
device, but yeah, you can answer. Yeah, sure.
there is no actually consensus on which is the best progesterone to give as of now. But yes, of course, recently, like in this SR, Dr. Grissinger took a big session on progesterone. I was there. And it keeps 1 year they say vaginal is the best micronized. 1 year they say intramuscular is by 1 year they say. But this time, as of now, the studies say that intramuscular progesterone gives you the best results. That is the new thing which is there. That I don't think in another 6 months it might change again.
So
Now,
actually,
But I think I agree with Anu that we have started again going back onto the intramuscular because we were giving in between we have stopped giving intramuscular. But as you said that like every 6 years, 6 months the crop rotates like in the farm the same way which progesterone to give, and then again single dose or you give like 3 times a day or you just give a sustained release. So I think still there is a lot of controversy when it comes to the progesterone.
yes, Archana
so
and
even
Anu,
I would switched,
I
ma'am. I
just
have
want to
switched
tell
over to
that,
intramuscular.
Anu, I want to tell you that recently even I heard one lecture. It was in the PCOS, podcast by one doctor, professor from England, and he was discussing with Dr. Duru, and then what he said was, these injectables are actually, I'm talking about the ART only. They're not very essential to be given in all the ART patients, but definitely they will decrease the miscarriage rates. That was his take. So yeah, you very rightly said that these are changing, and we really have to rest of the time,
Now again, ma'am, what we have to understand the physiology. If we are doing a natural cycle, probably just
course.
Yeah,
Yes,
just a vaginal progesterone would be
yes, yes.
fine because we'll have we'll have a corpus luteum which will produce endogenous progesterone. And
Yeah,
then we won't need these injectables there. And there we can just do a micronized vaginal progesterone. Even dydrogesterone is giving good results nowadays. So I
yes.
would see what can, but if I'm using a frozen HRT cycle, definitely I would go for an IM progesterone because I don't have that corpus luteum which will
No,
support.
but here again, Anu, we have this modified natural cycle. It gives superb results because of the good endometrium and all. We don't have to give any estrogen, but only progesterone we start after trigger after 36 hours. We start the progesterone, and in that also, there's no need of giving any injectables. That is my take. And
See,
vagina
ma'am, even
is
in
the
natural
best.
cycle, I mean, I'll tell you my experience. I do give vaginal gel, I give. I don't take chances because this is an IVF cycle. But
Yes.
I do not do intramuscular because I am progesterone is painful.
Yeah.
But yeah, there is an alternative of subcutaneous also aqueous. That also we can give.
That is
There is
also
no problem.
painful, Anu. That's also very
Yeah,
painful.
25
Sub-
milligram aqueous is enough, 50 mg of IM is enough. 600
yes.
micronized progesterone is more than enough.
Yeah.
So
So I
I
agree.
think
Some form of vaginal has to be given.
yeah.
Some, vagina is the best because the first pass through to the uterine cavity.
I should congratulate Dr. Basser on her wonderful
Yeah.
talk. My internet
Thank
did
you.
disconnect in between, but it's a pleasure being here and what a wonderful talk.
Yeah.
Thank you, Anuradha. Thank you, Kanti. Thank you, Dr. Sabine. Thank you so much for being here for us and for your valuable inputs. Thank you so much. So I'll now hand over again to Kalyani and Rudri to take the proceedings further.
Yeah. So thank you, Basir ma'am, for such a wonderful insight. We all had a lovely, lovely brush up of all the hormonal supports that's needed in IVF. Thank you to all the chairpersons for joining in today on just one call away. I'm really grateful to all the seniors out here that just एक call किया and everyone was ready to join in करके. So thank you so much again for joining us. To move forward, hello, can you hear me?
Yeah.
Yes, ma'am.
Yeah. So to
Yes, I
move
can
forward,
clear to hear.
let's move to the second part of the lecture. I would like to invite Dr. Naina Patel ma'am. Dr. Naina ma'am is the medical director for the Akansha Hospital and Research Institute located in Anand city of Gujarat and Xavier IVF. She is considered as a pioneer in the field of IVF and surrogacy in India. Almost 1,737 surrogate babies are born at her center. She is also the president of Obs and Gynae Society of the Gujarat, SOGOG 2010, founder president of Gujarat chapter ISAR. She was also invited at the Oprah Winfrey Show, Hard Talk, TED Talks, and Josh Talks. Authorized number of research papers, book chapters, and published and edited her own book, Advances in the Assisted Reproductive Technologies. She's also one of the pioneer reviews for JHRS, JRHM, and multiple magazines. Yeah. Published and treated world's first case of thin endometrium by bone marrow derived cell therapy in CERM journals. Published first pilot study on autologous bone marrow derived cell therapy for the thin endometrium patients in Journal of Regenerative Medicine. Her research interests are regenerative medicine, gut microbiome, ovarian and endometrial biomarkers, and PCOS. Welcome, ma'am.
Thank you, Naina Ben, for joining. I
Only
visited.
Naina, Archana. Yeah.
In Gujarati, you have to say Ben, but I visited her center. It's an amazing center, and the way she takes care of her surrogates. So over to you, Dr. Naina. Everybody is really waiting and eager to listen to you.
Thank you, Dr. Archana, Kalyani, and everyone else, and Dr. Rudri for having me over here. Slide share, yes. So it is quite interesting at Dr. Archana's talk and the discussion. Today I'll be speaking on managing IVF pregnancies via surrogacy. We look into the medical, legal, and ethical perspective from all aspects. So we know that surrogacy, it was before like you, me decide the surrogate is there, the couple is there, and we start. but not anymore. Step by step, the government has gotten various guidelines, and ultimately in 2021, we had this Surrogacy Act, which has beautifully covered the legal aspects also. They've tried to cover some medical aspects also. And this was before the law was being made. On 22nd January 2020, we had the team from Delhi as well as Gandhinagar, some union ministers and the Rajya Sabha members, some Lok Sabha members who had visited our hospital to get a first-hand information on what exactly, how we are doing, what is the insurance scheme that you take. And they had interacted with the surrogates, they had interacted with the intended parents also, and the hospital staff to get a better understanding when they were making this act. So normally we would want to start with the obstetric and the medical aspects, but surrogacy practice is one such thing where the couple starts planning to have a baby with the legal aspects first in the lawyer's office. We know that now there are 4 steps in which we need to get the clearance from the appropriate authority before we even embark onto the journey of surrogacy. First is the certificate of medical indication. Second is the eligibility for the intending couple. Third is the eligibility for the surrogate mother. After this, they will be called in by the judicial magistrate, a first-class officer, who will interview both the couple and the surrogates and eventually give the court order of parentage and custody. And when we get this certificate of essentiality, only then we can start the surrogacy treatment. I will just look into the criteria for the surrogate mother. It should be a willing surrogate mother who is not forced into this, age group 25 to 35 years. She should have her own child, age 2 years or more, without any complication during her previous pregnancy. Husband's consent is necessary. If single, she can have a mother, brother give consent. She shall not donate eggs for the same couple. She can be surrogate only once, has not been surrogate before, or does not have 3 failed attempts of surrogacy before. This willing woman must meet the couple, meet the lawyer, and then approach the appropriate authority. She will require all the screening reports, medical and psychological fitness certificate. There will be altruistic surrogacy only, where no charges will be given to the surrogate mother, except for the expenses which are there for her travel, stay, whatever. Her fees, then medical expenses, that is the travel fees, or she has to take medications, all that will be given, but nothing beyond that, and the insurance coverage. So why this ever married woman, 25 to 35 years? Because they were previously surrogates in their 22, 23 also. This will have the reproductive maturity and she will be proven fertile. One biological child, that means she has experienced pregnancy. We know that primary is always a black horse that we consider. Here we know that her pregnancy had been smooth and she had no other problems during pregnancy, and she can manage postnatally a child. She knows how she can remain connected to her child and what will be the feelings when she has to give away the child. Husband's consent, so we know that she has a family support and it is a legal, transparent procedure. They do not want any genetic link of the surrogate with the baby, so that there is no legal or future identity issues. Only once in a lifetime, so that the physical strain on the surrogate mother is prevented and commercial exploitation is prevented. She must be willing, so she ensures voluntary participation. This will discourage the trafficking, coercion. And eligibility certificate from appropriate authority means she is legally safeguarded as well as physically also, and medically she is safeguarded. And the medical and psychological fitness certificate ensures she is physically and mentally prepared for the journey. We all know that prevention is better than cure. So for this act is beautifully made. We have to take the consent of the surrogate mother, that is Form 2. And this surrogate mother consent and agreement form is very, very important. She has to be counseled about this full form in the vernacular language also. She knows that she'll be undergoing embryo transfer, what is the embryo transfer procedure, what medication injections she will have to take, and that there is no certainty that there will be a pregnancy or not, or there can be a miscarriage. And then once the delivery happens, it could be a normal delivery, it could be a cesarean section. General health insurance in favor of the surrogate mother is also important. And so once all these terms and conditions are explained to the surrogate mother and she endorses and the clinic endorses, then only this consent form will be presented to the appropriate authority. There is also a need of an affidavit of surrogate mother's husband or relative, which has everything from Aadhaar card confirming for whom she is becoming the surrogate, then the surrogate mother's affidavit with the relatives that yes, they've agreed, or the husband that they want to do it. So this affidavit is also very important. Screening, everything, right? First from her identity to her marital status, religion, number of deliveries, number of living children. So all the birth certificates of the living children should also be attached. Number of abortions, whether there was any hyperemesis, preeclampsia, diabetes, history of any copper T, etc. was there, any genetic abnormality, blood transfusion, substance abuse, then all other blood parameters are also checked for thalassemia minor, for all the kidney, liver diseases, sexually transmitted diseases, height, weight, BMI, and the physical examination is done in detail. Remember, these tests are to be done for 3 months prior to embryo transfer. So when she comes to screening to us, we have done the screening, the couple brings her, we do the screening, and then all the file goes to the appropriate authority. By the time they go to the judicial magistrate and they get the essentially certificate, it is normally 3 to 6 months, 3 months minimum. So again, when you take her for transfer, all the blood tests should be carried, because we had one such experience when couple got the surrogate mother, everything was submitted. And then I think it almost took 6 months. By the time we were preparing her transfer, she was already diabetic, like her HbA1c had gone up, her OGTT was abnormal, and we had to cancel that surrogate, and the couple is now arranging for a second surrogate. So before the embryo transfer, the report should be valid for within 3 months. Psychological fitness is by a psychologist or a psychiatrist. We have this 6 questions are minimum asked to the surrogate mother, independently with the psychologist only or the psychiatrist, that whether she has been forced into it, whether she has understood this, is she on any medication, or is she having any drug abuse, does she know that what happens to her if she has to give away the child, will she be able to do it? All this is analyzed by a psychiatrist, and if the surrogate mother appears nervous or not fit for these answers, then also the psychiatrist will not give this certificate, that is form 14. Insurance coverage also should be put up for 36 months, and it's good. It covers the complicated pregnancy-related complications and postpartum, and it should be from IRDAI recognized insurance provider. And it will also cover the medical expenses if it happens during the postpartum period. Once this is done and the appropriate authority has checked all the documentations, all the forms, then it goes to the judicial magistrate, where they will call the couple and the surrogate and her husband or a relative for the interview. And they will ask all the questions to see that again there is no exploitation, no commercial aspect, and she is willingly doing it. Only once they do this interview, they will issue this pre-birth affidavit. So it's very clear now that this baby is going to be from the IVF embryo placed, and that the baby is born will be of this couple. So later on, there is no dispute regarding this. Even the number of embryo transfer, previously there were twins, triplets, fetal reduction, will now not happen, because we are allowed only to transfer one embryo in one treatment cycle. Only in explainable circumstances that up to 3 embryos may be transferred. We had one couple where first blastocyst failed, second failed, third time we had to put 2 blastocysts, and the surrogate mother was the real sister-in-law, delivered twins. and maximum 3 times. If 3 times the transfer fails, then that surrogate mother needs to be changed. The couple has to bring another surrogate mother. This is the consent form for withdrawal. So at any stage before the embryo transfer happens and the surrogate changes her mind, this form has to be signed, and we have experienced that also, because when it takes a long time, the surrogate mother, one, she got naturally pregnant, one, she did not want to continue, and we had to fill up this form and submit to the appropriate authority. Then medical termination of pregnancy, where we have to explain to her that because of this reason, we are going to, there is abnormality, which is found, which is not viable. This form is filled up and the termination of pregnancy is done. But in case of emergency, if there is bleeding and immediate termination is to be done, we can do it and submit this form later on. No individual shall promote or pursue unless for specific purposes. And all the potential side effects and consequences of these procedures are to be explained to the surrogate mother in the vernacular language. And a surrogate mother has to right to retract before the implantation of human embryo in her womb. And the eligibility certificate will need all this documentation: the application letter, that is Form 2, ID card, proof of the surrogate, self-attested copy of the marriage certificate, birth certificate, then an affidavit from both of Commissioner for consent of surrogate mother, medical psychological fitness certificate, then an affidavit of the surrogacy from registered oath commission stating that shall not act as surrogate mother by providing her own gametes, and a self-attested copy. If she is a divorcee, then the divorce certificate. If she is a widow, then the death certificate. So these are the documents which you will be required to submit before you can get the eligibility for certificate. And this is the birth certificate, where they have mentioned no mention of the surrogacy, but it's just that the hospital plays, and we have to attach a separate paper showing that this was a surrogate delivery. But the birth certificate will have the name of the intending parents. This is one of the birth certificates. The baby was delivered on 18 May 2025, and this is how the birth certificate will be. Completion of surrogacy is another document that you will need. So once the delivery happens, you have this completion of surrogacy, this whole document which is there, which you have to submit to the appropriate authority. And this is the format of that completion of surrogacy procedure. So post-delivery, within 1 week, you submit Form 2, which was the consent of the surrogate mother and surrogacy agreement. Then that pre-birth affidavit, that is the legal parentage declaration. And third, online we apply for birth certificate, because the birth certificate can take 2 weeks. So online application, what we have done for the birth certificate should also be attached, and this 3 certificates should be submitted to the local municipal authority. It is very important to have a surrogacy coordinator also. The surrogate may be staying with the couple, may be staying at her home place, whatever it is. Even she is the real sister also, it is very important that you have a surrogacy coordinator who will remain the main contact for the surrogate. And as you are taking antenatal care and delivery, it becomes your responsibility that surrogate is taking proper food, her documentation, legal forms are properly maintained, all the tests at the scheduled date she comes, all her appointments, also offer emotional support and counseling. Because even I saw in a real sister-in-law, sometimes she gets a little nervous. You have to get a emotional support and ensure medical, ethical, and legal compliance. So this is also very important, that we have a coordinator who every twice in a week at least calls, finds out what's happening to her. Is she taking her food properly? Somebody sick in the family? Any support she needs from the clinic? Any support she needs from the couple? Whatever, we have to be continuously in touch with the surrogate. Counseling all throughout, before and during pregnancy, that she will be emotionally separated from the baby. We have to counsel if there is a miscarriage or termination, psychological stress if she is under that, any social stigma she is fearing, or family acceptance. Then the pregnancy risk also, if there should be very nicely counseled to her. And we have to understand from time to time her any demands, and physical as well as emotional. Psychological well-being is very important for the surrogate, and it has a deep impact on the baby that's growing inside. We know that if she goes into depression, she has excessive anxiety that can affect the fetal brain. So that regular counseling to address anxiety, detachment, and emotional stress should be there. Emotional support before, during, and even after pregnancy. See that there is monitoring of depression and burnout, and include her in all decision making to ensure her self-worth and confidence. Now, endometrial preparation, it's normally a frozen cycle. It's not a fresh cycle now anymore, because there is no synchronization. All these permissions, etc. You create the embryos, blastocyst, and then transfer. All these females have functional ovaries. And we know that the HRT cycle with down regulation or without down regulation are the best. But now we are slowly learning the epigenetics and also the role of corpus luteum in a smooth pregnancy. For our surrogate mothers, we want to avoid preeclampsia, a very big baby, which are the side effects of the frozen throat transfer cycle due to the HRT given. So now more and more we are trying to do a natural cycle, so she has less of drugs to take, or a modified natural cycle. But the tip here is that we should know that she is sterilized. If she has a family planning surgery done, it's very smooth. If not, then continuous counseling that she will not be having any intercourse with her husband. All this has to be done properly managed. So we are encouraging now more of natural cycles or modified natural cycles, though for certain surrogates, we also do the HRT down cycles without down regulation. This modified natural cycle, as I said, it mimics the physiological hormone patterns and reduces the obstetric risk. So clinical care of surrogate during pregnancy and labor. All the staff must be aware of surrogacy laws, and they must treat the surrogate with equal respect and standard obstetric care. It's not that this couple surrogate has come for a checkup, let her come last, we'll finish all our pain patients. No, she has to be given equal respect, equal care. Then she can, if she has any problem, she can have a clinic stay with the consent of the couple. She needs frequent monitoring and prompt care. We cannot say that, okay, you've got fever, stay at home, take this medication. Just get a blood test done if you can arrange it at a place. Find out, because this is now COVID time. We had one surrogate mother. She lives in Ahmedabad. She had COVID and she came to us. So these things are happening. Then 24/7, we should be ready with the clinical supervision. A phone number should be given to the couple and the surrogate mother where they can immediately contact if they find that there is any abnormal sign like spotting or fever or severe vomiting, anything. No self-medication or unapproved injection should be given. If she has to meet some other doctor, let her talk to the doctor and then give the medication. No physical intimacy during surrogacy period. Diet, we have to very well tell her that please take healthy diet, the greens, the vegetables, proteins, etc. Hygiene is also very, very important along with the emotional health. And all the warning signals should be given, like excessive headache during leg, excessive edema, or the baby is not moving, there is spotting, whatever is there, she should be properly guided, and a written document should also be given. We prefer every checkup, the general checkup every 20 days, 6 to 8 weeks early confirmation with heartbeat, 11 to 13 NT. We don't do double marker, we prefer to do NIPT in these patients. Then 20 to 22 weeks anomaly scan, but we do extra scans and prefer to do monthly scans so that we see that the baby's growth is proper and there is no other abnormality. Holistic approach. I know one couple who have their surrogate, they asked us whether she can go for Garb Sanskar. We selected the right person. They are getting her Garb Sanskar every day. She's enjoying it. The mental anxiety has gone. Yoga during pregnancy. We give the healthy diet chart, what she should be having. Advice about hydration, dental care. What is the mild activity or maximum physical activity she can do. Adequate sleep and rest, and hygiene and personal care. So, intending couple requested, surrogate mother agreed, and it's going on very well. Mode of delivery, it is based on surrogate's past obstetric history. One, the present, what she is having during the pregnancy. Are there any signs of breech, or there is low lifer, what it is. then any previous C-section will decide the delivery, which is going to be mostly C-section. We have to avoid any prolonged labor, risk on the mother as well as the baby, and also the poor neonatal outcome. So we do not want to have any poor neonatal outcome also. Breastfeeding by the surrogate mother. If mutually agreed, surrogate may breastfeed the baby for first 15 days postpartum. Then that will support the neonatal immunity and early bonding. But which should be in a medically supervised and ethical manner. We should see that the surrogate is ready. The surrogate sometimes agree to give milk from their home also, where we have a human milk bank, and we get it collected from there, and the couple takes it and gives it to the baby. Or the couple can directly go there, collect it, give it to a bank, and then use it as and when needed. Mainly we are worried of pre-eclampsia, eclampsia, gestational diabetes, any urinary tract infection, and post-delivery stress incontinence. Rare amniotic fluid embolism, PPH. When we were doing surrogacy before, we had at least, I think, 2 obstetric hysterectomies due to severe bleeding. And there was one death of the surrogate because of the COVID, because of the swine flu, not because of any obstetric emergency. And we know that there are risks are not unique to surrogacy. They require close monitoring. So this surrogate mother who has conceived naturally may not find the difference between this natural pregnancy and the IVF pregnancy. So little bit of education on IVF. They now, if you counsel them, they understand that what is IVF, what is embryo transfer, what care I should be taking, how many embryos you are putting, they understand. Planned delivery prevents complication and stress, and timely decision making by obstetric team is critical. And whenever you are making this decision, involve the surrogate for the decision. The couple may feel that I want this delivery on this date. The surrogate may not want it. She has her own problems of wishes. So both should be taken after thorough. They are like a family. So you have to counsel and take that decision. Postpartum, we do a monitoring for 3 months. We generally give a call, and after 1.5 month call her for checking the uterus, blood profile. We repeat the infectious disease profile, that is HIV, HPSAC, and hepatitis C every 3 months during pregnancy also. And post-delivery after 3 months also we check it, and we give the report that you have not had any of these infections during pregnancy. That is also very important. Ensure proper nutrition and rest. Schedule follow-up visits for physical recovery. We can also support, we definitely give them iron and calcium for 3 months. Then post-delivery, after 3 months, what all care she should take. And tell her that you should not have your pregnancy again in a short time. If she needs any barrier contraception, IUD, we also help with that. And respect and acknowledge her role and well-being. That is very important in a surrogate care. Finally, look at the ethical aspect. Surrogate must provide voluntary informed consent, that is respect for her autonomy. She should be fully aware of her rights and that she can withdraw, that we give it the counseling. Ensure for her physical, emotional well-being. Quality medical care and psychological support is important. Then we have to prevent any physical strain, emotional stress or trauma. Unnecessary medical interventions, like give her this many tablets, like post-transfer support. We should not go overboard if she conceives. We have to keep the medications, what are 100% necessary and what are like optional, we can always not give it. Ensure the surrogate is treated fairly, respectfully, and safeguard against coercion, exploitation or discrimination. I'm just giving one first case after the act came in. This patient was with chronic kidney disease. She got her surrogacy certificate from Vadodara, got her surrogate from Vadodara, obtained the essentiality and NOC. Everything was done, baseline investigation, and we did a single blastocyst transfer. Surrogate conceived. She had heartbeats at 7 weeks, and then at 9 weeks she comes with bleeding. And the couple brings, and couple thought that she must have done some household work there, and that's why she got it. So we did the DNA, we checked the POC, and it was a triploidy. And it was such a devastating situation, both for the surrogate and the couple. Finally, surrogate withdrew. Now Right now, the couple has come with a second surrogate. It took them almost a year, and we are about to transfer the embryo. But then we have decided after this that for all surrogate pregnancies, we do a blastocyst and we do a PGTA and transfer only a PGTA normal blastocyst. And when I check the literature world over, they prefer that in gestational pregnancy, it is better to transfer an embryo which is PGTA normal, so that there is no such heartbreaking situation for the surrogate and the couple. Now, conclude, I'll say that surrogacy is on the rise. Screening of the surrogate is key to safe outcomes. Legal and ethical compliance is a must. So follow the surrogate act strictly. Counseling ensures preparedness and support. Even postnatal care and follow-up are essential. Transparency and documentation are crucial. Prevent exploitation through awareness and regulation. Thank you.
Excellent, excellent, very crisp, clear talk, Dr. Naina. It was like just, everything point to point here clarified. Very, very simple. I think I learned a lot. So that's what is the take home from me, that I learned it, and I'm sure everyone must have enjoyed your talk. And nobody calls you queen of surrogacy without any this thing, that there is so much to learn from you. So chairpersons, if any notes anybody wants to do, or any questions on that? I think everybody understood so well, Naina ji, that people are so happy and so like thinking that how so beautifully a lecture is done.
Thank you so
really
much.
Good. So thank you so much for joining in, and thank you so much for enlightening us on such a difficult and a very tricky subject. It's quite tricky. It must not have been easy for you to really handle 3-4 different parties. I mean, different stakeholders. That was very nice. Thank you so much.
Thank you, Madam Kamini Rao, for being here and listening to the talk.
I think now since Dr. Kamini Rao is here, let me introduce Dr. Kamini Rao. And can I have CV of Dr. Kamini Rao, Shruti? Or I just I remember Madam CV as it is.
Just 1 minute.
Okay, I can just. Welcome, Dr. Kamini. Thank you for joining in. So Dr. Kamini Rao is a Padma Shri, Professor Dr. Kamini Rao, and she has present designation as a co-founder and chairperson of Medline Academics, co-founder, medical director, Dr. Kamini Rao Hospitals, and she has so many achievements. Padma Shri in 2040, Karnataka State Award. She is honored with Karnataka Award, Lifetime Achievement Award Society in 2021, and she's being honored with the BC Roy District Award, Lifetime Achievement Award for IVF and infertility. And I think Madam is the best thing is she is still well-grounded person, and always whenever you meet, you have something to learn from her. And when I was in Bengaluru, I met many of her pupils, and they said that we have a really good academy, and we are so much well connected to ma'am. So it is really, really good and heartening to hear that your students and your pupils still, like they just respect you like anything. And whenever I meet Dr. Kamini Rao, she's always like, oh, how are you, Archana? I mean, she'll remember you by your first name. And I know Anu is also one of the madams, student also, and been with Madam, and Mahesh also. So I think we are really happy to have you here, Madam. And we would like you, this is a Fertilogix series where we are cross-connecting with different states in the collaboration with MP ISAR chapter. And we really want to know all our fellow colleagues who are practicing IVF and ART, and whatever from sitting in one of our, rooms, consulting rooms with our laptops and all, we can really educate and give knowledge and pass on good information to our colleagues and our fellow colleagues who are sitting in even remote areas of the country. So that is the whole objective of this series. So over to you, madam, for your advice and any updates and inputs you want to give to us.
Well, Archana, I must say it's always a pleasure to reconnect, join, and of course, I see Anuradha here as well. Because you see, these are all my colleagues, and they're doing much better than what I was. I'm an old model. They are the Virat Kohlis of today. And I think what we need to understand is that knowledge is for sharing. And this is something that you people are doing a step ahead. You're connecting digitally to tier 2 and 3 cities who would not have had the opportunity of meeting or listening to many of the stalwarts in the field of medicine. And this is only possible when you network, when you share. And when you share, you gain more knowledge because it's not only teaching, but learning as well. And in fact, I can see the enthusiasm in Anuradha's face because this all, I believe that the day you stop reading, you become illiterate the next day. And more importantly, youngsters who have been with me for so many years have sort of imbibed the same, fire in the belly to read, teach, learn, and innovate and not be stagnant. And with this kind of program, I'm sure all of you are doing extremely well. And I'm sorry I'm late because I was in another meeting, but I'm sure, it doesn't wait for any one person. Knowledge must be on the move and it shouldn't stop for anybody. And I wish this webinar all the best. And I hope more such webinars go through and I can see more of my students everywhere. And that is the joy, that is the dividend, that is the product that I think, gladdens my heart. It's not the money in the bank. It is the bright faces that are doing wonderful ethical practices that gladdens my heart. Thank you very much for calling me. Yeah.
Thank you, Kamini madam. Very truly said that our treasure is all the smiles we pass it on to our patients and the IVF patients when they go home with the baby, and our obstetric patients when they go home with the couple and the parenthood, and all our students and all our fellows who get something from us, and knowledge is for sharing. Well said, madam. Thank you so much for joining in. So over to you, Dr. Kalyani and Dr. Rudri for taking it over to Pat.
Yeah.
Thank you, ma'am.
Thank you, ma'am.
Yeah. Thank you.
Thank you so much, ma'am, for having with us. And it was a pleasure to hear Dr. Naina ma'am's lecture. Going forward, we will have a very, very good and important panel discussion on the topic that is IVF pregnancy just a job or it should be a multidisciplinary approach. So for that panel discussion, we will be having two very, very experienced moderator with us and a team of very experienced panelists with us. So moving ahead, I would like to introduce our moderators, Dr. Aruna Murlidhar ma'am and Dr. Mahesh Korigil sir with us. So Dr. Aruna Murlidhar ma'am is a senior consultant OBGY at Cloud9 Hospital, Jayanagar. And ma'am has a special interest in maternal medicine, obstetrical critical care, patient safety, adolescent health, menopausal care, and medical education. Ma'am has been the author of so many prestigious books like 9 Months, A Journey of a Lifetime, author of Growing Up Right. And ma'am has been a trainer for MRCOG examination and has been a reviewer of so many important journals like British journals and International Journal of OBGY. And to her credit, there are multiple credits and awards. We welcome you, ma'am, as our esteemed moderator. Next, I would like to introduce our very own Dr. Mahesh Kurigil, sir, as our next moderator. Sir is National Strategy Director of Nova IVF Fertility and is a senior consultant of Nova IVF. He is based at Bengaluru, and sir has been holding so many various prestigious posts in various organizations, and he has been into field with more than 17 years of experience with him, and he has trained multiple gynecologists to become ART specialists, and sir has published more than 5 research papers at various international index scientific journals as the first author. We welcome you, sir, as our esteemed moderator. Next, I would request Dr. Shruti to introduce our panelists. Dr. Shruti, may I hear from you?
Yes, Dr. Rudri.
Yeah, please go ahead.
So good evening to all respected consultants who have joined us for this webinar. I would like to introduce our panelists for today. So we have with us Dr. Madhushri Deshpande, who is MBBS MS Fellow in Reproductive Medicine and is currently with Junior Consultant post at Devika Maternity Hospital and IVF Center, Kalaburagi. Welcome, Dr. Madhushri. Next, we have with us is Dr. Archana Dadinagar, who is Senior Consultant at Dadinagar Hospital, Navnagar, Bagalkot. Madam is a MBBS MS OBG, Fellowship in Minimal Access Surgery, Maternal Child Health, and Cosmetic Gynecology. Next, we have with us is Dr. Shilpa Ellur. She is Senior Consultant, Reproductive Medicine and High Risk Obstetrician at Milan Fertility Hospital, Bangalore. Madam is MBBS, BGO, DNB, and Madam has various training courses associated with her. Next, we have with us Dr. Shobha Shavi. She's consultant at Sanjeevani Hospital, Ilkal, Bagalkot. She has been the past secretary for Bagalkot OBG Society 2022 to 2025. Her area of interests are fetal medicine and genetics, recurrent pregnancy loss and obstetric medicine, critical care and obstetrics, NDVH preventive medicine, and holistic health. Next, we have with us Dr. Aviva Pinto Rodriguez. Madam is Director, National Strategy Group, Clinical Director at Nova IVF Fertility, Bangalore. Madam has graduated from KMC Mangalore and received the Best Outgoing Student Award from Manipal Academy of Higher Education. Madam has a diploma in reproductive medicine from the University of Kiel, Germany. Also has 30 plus years of experience in the field of reproductive medicine. Welcome, Madam. Next, we have with us Dr. Apurva Reddy, who is MBBS, MS, DNB, OBG, Director at Phoenix Women and Cardiac Center, JP Nagar, Bangalore. Madam has a fellowship in reproductive medicine and has done her infertility training from Brussels, Belgium. Welcome, ma'am. Next, we have with us Dr. Archana Dwivedi, who is Director, Obs and Gynae, Sterling Hospital, Vadodara. Madam has been the President at BOGS 2024-2025, has been the past President as well. Madam has been the winner of Jagdishwari Mishra Award at ISO PARB. Welcome, Madam. Next, we have with us Dr. Ruta, who has been working as fetal medicine consultant at Ruta Hospital and IVF Center for since a year and has started her new venture since 2016. Welcome, Madam. Now I request our moderators to please go ahead with the panel discussion.
Good evening, everyone. It's indeed a pleasure to be co-moderating this panel with Dr. Mahesh Koragol, a good friend of mine. And a warm welcome to all the panelists. I think I know some of them, Dr. Shobha Shabi and Apurva and Dr. Aviva Pinto. And very nice to meet all the others on the panel. Thank you, Archana Basir, Madam, for giving us this opportunity. Thank you, Dr. Mahesh, for involving me in this panel. And without any further ado, I think we will dive into the panel. Essentially, we all know that ART is increasing. And unfortunately, although we do not have any Indian statistics, we know that literally every single nook and corner of India have fertility centers sprouting, mushrooming. And let's say about 5 or even more % of pregnancies are IVF or ART procedures, and they come as a package of obesity, diabetes, hypertension, hypothyroid, multiple pregnancies, a whole load of anxiety. And I think more than anything else, we all have to be very empathetic towards them. And empathy forms a very important part of dealing with our IVF pregnancies. And the panel literally says a multidisciplinary approach. And we all know, as obstetricians and fertility specialists, that we all have to work as a team. We've got fertility specialists such as you, obstetricians, gynecologists for the procedures, fetal medicine specialists, geneticists, endocrinologists, physicians, cardiologists, even nephrologists and rheumatologists as well. So a true pool of multidisciplinary management for IVF. We're going to be discussing these cases: advanced age of the woman, advanced maternal age as it's called now, AMA, advanced paternal age, higher order pregnancies, preterm labor prevention, interpretation of first trimester screening results, especially in IVF pregnancies, comorbidities and preconceptional care, which is extremely important even before the cycle is started. So let's start with, I think we'll start with alphabetically. So Dr. Archana Dwivedi, would you mind taking this question as to what are the genetic outcomes in IVF and ICSI, and how would you counsel the couple about these outcomes? Dr. Archana Dwivedi.
I think Madam
Okay,
she's not
okay.
started the video yet.
Oh, all right. But is she around?
Yeah.
Well, we can go on to the other Archana, Dr. Archana. Not Dr. Archana per se, but
Archana Dadino.
yes.
Yes. Good evening, ma'am. Yes, the genetic outcomes like in IVF pregnancies, actually, it's not really associated with increased risk of chromosomal anomalies. But when there is a severe male factor or female factor infertility, there is an increased chance. And also when we do ICSI, where there can be a de novo chromosomal abnormalities arising, and it can allow for chromosomal or gene defects to be transmitted, which could be naturally eliminated or lost.
Yeah, absolutely. Yeah. Anybody else would like to take on this question? What else do you generally counsel women about?
Dr. Shilpa? Shilpa is around?
Yeah. So in case of a patient with reduced ovarian reserve, or in case of a patient with primary ovarian insufficiency, there may be an increased risk of mutation of the fragile X gene. So in this case, we have to counsel the patient about the genetic counseling was important before we embark on the IVF cycle. And also we have to counsel about there is a slight increase of imprinting syndromes, which are very common in IVF cycles. But rare, but yes, that can be a possibility. So counseling is very, very important about this.
So, but I just need to ask you, do you all have geneticists around you or in your fertility center whom you can readily refer to?
Dr. Aruna, in our center, we have a genetic counselor. For all the IVF cases has to be sent to her before we start the IVF cycle.
Very good. Oh, that's great. That's wonderful. And I think that's a very important aspect of even starting a fertility center. That's great. We'll move on to the next question. And I think Dr. Apurva could take this question.
Yes,
in terms of the sorry?
No, I said yes, I'm here.
Yeah. In terms of pre-implantation genetic testing, are there any specific considerations in such cases that you would like to sort of consider?
I think, ISAR had recently only come up with, a statement saying that non-invasive testing shouldn't be offered to patients, and, invasive testing is the way forward for us to kind of do any kind of pre-implantation genetic testing per se. So the moment we say that it is an invasive testing, so it means that it shouldn't become synonymous for all patients that we are kind of going ahead and doing IVF per se. So it's definitely important that we pick and choose the class of patients that we are offering PGT A to. So of course, in case if there is an existing known mutation that we have in the couple, or if there is a thalassemia minor or any other heterozygous factor which is there mutually between the partners, we would definitely opt them to kind of go for a PGT-M and then followed by a PGT-A for those patients, irrespective of the age spectrum per
Your
se.
internet is slightly unstable, I
But
think.
in our practice, patients who've had more than 3 miscarriages. Sorry. Am I better now?
Yeah.
Yeah, go ahead.
Am I
Go ahead.
audible now? Yeah.
You're audible. If there's a problem, you could
So
just switch off your
in
video, maybe.
cases where
Yeah.
we feel that the age spectrum is more than, yeah. So if with respect to the age group, in case if we feel that there is advanced maternal age more than 35, or if they've had previous history of miscarriages, so in these patients again we kind of go ahead and offer them a PGTA.
Sure. So
And
the
of course,
selection is
if they've
extremely
had
important.
recurrent implantation failures as well.
Absolutely.
One more very
But
important factor is that we have seen for a couple of patients wherein if we send 6 embryos for biopsy, 5 embryos turn out to be abnormal, and then you get 1 or 2 embryos which are, let's say, a low mosaic, or who kind of have a questionable transfer efficacy. So it's very important for us that we treat these embryos extremely valuable, and that we need to treat them more like diamond, and even more precious. So even though
Yeah.
if there is a low mosaic which is there, and if it is the only available embryo that we have, then I think we need to kind of have a discussion with the couple, and then go ahead and consider transferring it, and not discarding the embryo just based on the merits of one PGTA.
Right. Yeah, absolutely. But in terms of the PGT pregnancies, IVFs, do you see any changes or differences in the implantation success rates? Do you see anything in particular that you're worried about? How do you counsel the lady about that?
The biggest problem kind of arises is in case if a PGTA embryo doesn't implant. You almost are anticipating almost a 70-75% implantation rate, and if the embryo doesn't implant, or worst case scenario, if it implants and then results in a miscarriage, so it becomes very difficult for us to kind of counsel the patients, because there aren't so many factors that you're kind of looking at. It becomes only the uterine parameter per se, and all of us know that it's very, very difficult for us to test the uterine factor, or the the immunological factors per se, and be very specific in the treatment aspect.
Absolutely. Yeah. True. Lovely. Dr. Aviva, Dr. Mahesh, would you want to propose this question to anybody? You can take this.
Dr. Aviva, I think, is the best person. She has a
Yeah.
lot of experience in dealing with the frozen embryo transfer and fresh embryo transfer, because especially those days, in olden days, I think Madam and we used to do a lot of fresh embryo transfers, and later the trend changed. I think Dr. Aviva would be a best person to answer if there is any difference between frozen embryo transfer and fresh transfers in terms of outcome.
Yeah, there is a moderately higher success rate with the frozen embryo transfers, definitely compared to fresh, because of the physiological environment, the high estrogen levels and other things, will not allow implantation to happen. And we don't normally put back embryos when the E2 levels are higher, because we are worried about ovarian hyperstimulation syndrome and things like that. But we also have to, I think, strike a balance, because there is a tendency to go overboard and do only fresh frozen embryo transfers nowadays, and that we need to understand that there is a higher risk of preeclampsia and larger babies and other complications in patients where we have done FETs, especially with HRT cycles, rather than, so if we are doing frozen embryo transfers, it would be better to use natural cycles or modified natural to reduce the risk of PT and other things. But yes, definitely, if frozen embryo transfer cycles do give us marginally higher success rates.
Right. Yeah, Sandy. Yeah, absolutely. So you still do you choose patients when you decide, it's a fresh or frozen? What kind of
Yes. Yes, definitely patients who are hyperstimulated, like PCO patients, those with, there's a cutoff for the estrogen level that we normally take. Some of us use 2,500, some of us say take 3,000. Now, those patients are a complete no-no because in those patients, first of all, we would have given an agonist trigger, and those patients are a complete no for a fresh transfer because of the risk of, first of all, they will not implant. Secondly, for the risk of ovarian hyperstimulation and other things. Now, that category of patients definitely will go only for a frozen transfer. Now, in the normal responders and the poor responders, we could consider doing fresh transfers, and we kind of individualize which patient we would like to go for a fresh transfer. If they have a good endometrium, if the progesterone levels on the day of the trigger were normal, things like that, then we still do a few fresh transfers. But I'll be honest, and I think that most of the people on the panel who do fertility work would agree with me that most of us tend to do more frozen transfers today than fresh, which maybe going ahead is not the best practice. So we should balance out and decide who should be actually taken for frozen and who should be actually, could go ahead with a fresh transfer.
True. So I think as obstetricians amongst our spectators, for us, it's important to understand whether it's a fresh or a frozen in terms of surveillance, especially for preeclampsia and larger babies, and especially even with donor eggs, etc. So thank you for that. Let's go on to the next question. What do you think are the considerations with first trimester screening and IVF pregnancies? Who do you think should take this question, Dr. Mahesh?
I
will take it, madam.
Yeah,
Dr.
who's that? Yeah, please
Dr.
go ahead.
Shobha.
Yes,
Good
please
evening,
go ahead.
everybody. It's great to be among you all and learn so much. Like in IVF pregnancies, these people need more screening compared to other regular antenatal patients, especially when they're at an advanced age. We will need to do more screening. So I would like to go ahead with OGCT, TSH, and other general examinations. And along with that, I'd like to go ahead with the first trimester NTNB scan and a double marker along with a PE screening also I would like to do, and a 2D echo also. If the patient's age is more than 35, I think it is better to go ahead with a maternal 2D echo.
Right. Now, Dr. Shobha, would you mind just talking about the first trimester genetic screening? I'm hoping that most of you would be doing the preconceptional or the pericycle investigations, including thyroid, HbA1c, and CBC and vitamin D, etc. That is, before the stimulation, because again, the TSH needs to be modified prior to the cycle, prior to the implantation. But in terms of the first trimester genetic screening per se in IVF pregnancies, what are the considerations that we have to take into account? Like,
main thing is
essentially,
whether it is a donor egg that we should know. If it is a donor egg, we should know the age of the donor, and if it's a FET cycle or a fresh cycle, that is also very important. And maternal age is also very important too. Like if it is more than 40, better to go ahead with NIPT than a double marker, I think. And like whenever we are doing double marker, better to combine it with PE screening also. And
yes. So most of us have obstetricians have moved to first trimester quadruple marker, which is, as you rightly said, double marker plus the PLGFS split ratio and the PL, essentially to see whether there's any risk of preeclampsia before 37 weeks, before 32 weeks, as well as risk of fetal growth restriction. So that's a very important factor that you brought in. Thank you. And as we know, I think decreased PAPA levels and increased beta HCG are seen, total HCG levels are seen in the first trimester screening as well. And there may be a lower fetal fraction of cfDNA when we do the NIPT essentially. Now going on to fetal outcomes. I think if we are not, how much time do we have? Can we go directly to the case discussions? What's the time limit that we have?
Ma'am, actually the session ends at 7:30, so I guess you have roughly 25 minutes. 25
Oh, that's it. Okay. In which case, I'll move on. We will move on to the case discussions. Dr. Mahesh, is that okay?
Yeah, that should be fine.
Right. I mean, just a little word about placental changes expected in IVF pregnancies in particular. Would anyone want to take this question and answer that, please? What kind of placental changes do we expect to see in IVF pregnancies as compared to spontaneous conception?
You want me to take that, ma'am?
Yeah, please. Who's that? Dr. Archana. Yeah, please go.
Yeah. So, one, of course, I think with respect to the embryo parameters, whenever we have, and we already know that some amount of alterations with respect to the embryo and endometrium will be there. So, the embryo reaction, whatever will kind of happen to help in the adhesion and invasion, everything else possible. So, as such, only that I think the placental invasion is going to be poor, or the placental perfusion is going to be poor, specifically with respect to ART patients. And these days, we kind of know even more that, specifically as we were discussing with respect to frozen embryo transfers, because of the change in hormonal parameters, everything, they have higher chances of developing pregnancy-induced hypertension or hypertensive-related issues, and all kind of placental abnormalities as well. So whenever we are kind of monitoring a fertility patient who's kind of got pregnant, and we are doing an obstetric scan, it has to kind of be more detailed with respect to placental evaluation as well, with respect to grading of how the placenta is and placental perfusion is, as opposed to what we would kind of consider in a normal pregnancy.
True, absolutely. And it's more likely for the woman to have a placenta accreta spectrum. Vasa previa is another thing that we need to look out for. So somewhere around 32 to 34 weeks, it's important to assess the placental location and ask a sonologist to particularly look for vasa previa, cord insertion site, placental shape, location, all that. So I think, as you rightly said, Apurva, it's important to do a placental surveillance and mapping as well. So we'll go on to
You brought up a very nice thing about vasa previa, because that is
yes.
where you need to screen the patient at very first trimester itself, 9 to 10 weeks, because in the later stages it becomes very, very difficult. So the mapping word was very rightly used for the placental this thing.
Yeah, but even towards the late pregnancy, I mean, if it's a low-lying placenta, this is something that has to be in our minds, and we have to screen for it towards the later trimester as well. You're right. Yeah. So I think we'll go on to the case discussions. Dr. Mahesh, would you mind taking that AMA?
Dr. Madhushri, are you around? Can you answer this question? First patient, she's a 42-year-old woman. She's an nulliparous woman who's undergoing IVF. And what do you think main consideration before she gets pregnant? What do you want to discuss with her? How do you want to counsel with her? Dr. Madhushri?
So, first of all, I would like to thank everyone for this opportunity. First of all, the thing that I would like to explain to the patient is the age-related complications or risks that are associated, because with increasing age, there are more chances of miscarriages, chromosomal abnormalities, a lot of cases with preeclampsia, even gestational diabetes. Most of these patients, because they're especially for this profile, because she's in her 40s, she might already be having some comorbidities. So I'll have to look into that as well. Another thing that I would like to basically tell her about is the genetic aspect of it, because with increasing age, there will definitely be some form of genetic abnormality, or at least there will be a chance of a genetic abnormality, in which case I would like to offer them, if they're going for an IVF or an ICSI, just offer them a PGTA to be sure that we have done at least everything that we can to give them a good pregnancy and a healthy chance of taking home a good baby. Another thing that I would like to tell her about is maybe consideration for, donor eggs, because 42, her AMH might be low, AFC might be low. So we'll have to talk about that, which will again prompt us to go into the psychological support and the psychosocial aspect of the patient, because it's not easy for a patient to accept that they might have to go ahead for a donor egg or anything. Most of these patients are looking forward to having a baby, but still it's a bit difficult for them to accept seeking a donor.
Right. So, Dr. Madhushri, do you particularly give them any supplements prior to your cycle, especially if they're more than 40 years of age, let's say? Anyone can take this question. Dr. Aviva, Dr. Apurva, Dr. Mahesh himself, Dr. Archana. So, is there anything that you do differently for a woman who's going to undergo an
We
IVF
would
cycle
require
with an
a
age of 40?
comprehensive
For
approach.
this
We
case,
have to, oh, sorry, somebody else is speaking.
Go ahead, Dr. Archana.
Yeah, see, you already said her age, the
Yeah.
comorbidities, obesity, nutrition, folic
Yeah.
acid supplementation. I think everything has to be go hand in hand. She should be given a thalassemia screening as well. And important thing I would like to add what Madhushri said is financial aspect, because such patients require maybe multi-speciality treatment later on. They may require more admissions and later on steps also, and dealing with the prenatal test also. So everything has to be explained on the financial aspect as well. Regarding the prenatal vitamins, this is the ideal candidate which should be started if she's not taking yet. And if she's obese, she needs to be on the diet and exercise. If she's on some abuse, as already mentioned in the slide, smoking, alcohol, we need to tell her that you have to avoid this. Lifestyle modifications are a very
Yeah, that's been mentioned. My particular question was about antioxidants.
yeah, we would like to start about the coenzyme Q, so which will enhance the mitochondrial function of the oocyte and the success rate would be better.
So you've noticed that the success rate is much better with the CoQ. Do you all agree with that?
It's
Is that
definitely.
evidence-based?
Yes.
Evidence as in our hospital evidence, I can say. I don't know about everyone else. And
Right.
also we can add DHEA or something if they're asking to go ahead with their own eggs.
Sure. And Dr. Shilpa, what are the particular risks with AMA in IVF pregnancies, or especially in IVF pregnancies, please?
So there is an increased risk of chromosomal abnormalities, especially the Down syndrome, and next coming the Edward and Patau syndrome. And there is increased risk of miscarriages because of associated chromosomal abnormalities, and the pregnancy-related complications like hypertension, diabetes, thyroid issues may be high, and there may be a increased risk of cesarean deliveries in this case of women's. And there is a fetal related issues like there may be a IUGR, or in rare case it may be a stillbirth. So and as we discussed, the placental issues also can be there in this case of patients, and we may experience a preterm birth also, maybe due to multiple pregnancies or maybe induced because of any medical issues.
Yeah, so it opens up a gamut of complications for us obstetricians to manage. And you can see the odds ratio here, especially for advanced maternal age. So advanced maternal age is something that we all have to deal with nowadays. Women pushing pregnancies to a much later age. So with that, I think in terms of maternal antenatal care, is there any modification that you'd like to do? I mean, any obstetricians in the panel? No, right?
I'm there, madam.
Shobha is
Yeah, I'm there.
Shobha, yeah. What would you like to do in terms of modifications in antenatal care?
Dating would take the date of embryo transfer instead of taking their LMP. That would give a proper dating in this pregnancy. And earlier ultrasound for confirmation, and maybe in first trimester we need multiple ultrasounds to know the viability of the fetus. And also if it is a multifetal gestation, because it is more in case of IVF, you should see for multifetal gestation. And if it is a multifetal, know the chorionicity and amniosity properly.
Absolutely. Absolutely. And in terms of the first trimester combined screening or the NIPT, any particular preferences?
There can be decreased fetal ratio. So, and also depending on the type of pregnancy, if it is a donor egg or donor this one, we should know the age of the donor egg, like donor, to know the proper, to give proper reporting in NIPT. That is also very important.
Yeah. So we prefer to do, much more closer surveillance of the fetus with monitoring the FGR. Although the NIPT, the first trimester screening may show a low risk of preeclampsia or fetal growth restriction, I still tend to do a sort of a regular fetal surveillance with growth scans, maybe one at 28 weeks and one at about 34 weeks before the final scan prior to delivery. And of course, fetal medicine specialists, sometimes endocrinologists for gestational diabetes, cardiologists for a 2D echo, especially if they're hypothyroid, obese, and maybe, gestational diabetes. These are the kinds of women who need a 2D echo. And in our practice, we've made that a regular sort of universal, not universal, but 2D echo. There are very specific indications for sending our women for a 2D echo to the cardiologist in order to predict the risk of PPCM as well. Yeah, all right. So I think we all have.
Regarding, the first trimester screening specifically, I think when we are doing a PGTA and when we already have a PGTA normal embryo, that it should not automatically kind of come into the space that, okay, we do not require a first trimester screening as such. And, we need to kind of ensure that we still do a first trimester screening for these patients as well. Because, that's what all the parameters, even the genetic labs also kind of recommend, because that's what patients also kind of ask us. We've already done a PGTA, so why do we need to kind of go and get another testing
I think that's
done?
when you have to tell them that it's probably the trophectoderm that you determine in the PGTA, whereas here you're going to get the actual genetics. Yeah, absolutely. So I think we'll go on to the very important twin pregnancy. And I don't know how many of you fertility specialists feel elated, or is it a feeling of mixed feelings, or you just feel, oh my God, it's twins? I don't know
How
how
many
you
of
feel
you
if it's a
like to
twin
do,
gestation.
yeah,
Huh?
2 embryo transfers?
I think
Yeah.
it's
Sorry, Dr. Aviva?
I think most of us prefer one healthy
Yeah,
pregnancy. Though the
that's right.
Because twin
Yeah.
pregnancy
trouble,
now
but
is called
for
as a
us,
complication of ART,
yeah,
not
we
a.
honestly consider it a complication, and that's very, sometimes patients really want us to, even in uteruses where there's a previous scar, where we tend to only do single embryo transfers and things, they actually argue with you for a double embryo transfer, and
Yeah.
it's very difficult to convince them that having twins is not a bonus. On the contrary, it is a complication. Yeah.
Dr. Aviva, just can you please explain to me what is the current consensus? Is it a single embryo or a double embryo with counseling? Like, I'm not able to still understand when you choose to do a double embryo transfer.
See, most of the cases we are doing double embryo transfers, single embryo, but moving on as your center gets mature, your labs, you're happier with your labs and you're very sure about your embryos. We are moving to single embryo transfers, especially in younger patients where we have good embryos. Now, of course, earlier we could do genetic counseling, I mean, genetic testing on younger patients. Now, the law honestly does not allow us unless there's a specific indication. But if you have a genetically competent embryo, then moving on to a single embryo transfer should be the way forward in the future. For me personally, I do single embryo transfers where any patient has a previous scar on the uterus, whether it's myomectomy or a hysterectomy scar or a cesarean scar. And in younger patients where they have specifically requested, or where it's a good prognosis patient, I am tending to try to move on to single embryo transfer. Yeah, because I personally feel that, it is the way of the future. And having
And do
twins.
you think that in those situations there is any difference with respect to the time to pregnancy? Because we know for a fact that there is going to be any difference with respect to the overall pregnancy rate per se. But specifically for a non-genetic tested embryo, in case if we are transferring a single embryo, do you feel that there is any difference with respect to time to pregnancy, or it really doesn't matter? I mean, not considering the twin part of it.
You mean putting in 2 embryos?
Yes. So in case if we opt to kind of, let's say, tell them that we want to electively do a single embryo transfer for a non-PGTA embryo, is there a difference with respect to the time to pregnancy as opposed to if we are doing a two transfers, two embryos transfer?
There is a marginally higher pregnancy rate with 2 embryos. But in good prognosis patients, again, if they are not PGTA embryos, I still think we could, counsel them and offer them. It really, the difference in the success rate may be just about 5% or 10%, not more than that. Not a very gross difference in success rates.
There are two things.
Dr. Mahesh, yeah.
Yeah, there are two things I would like to tell you. One is the recent ERT Act states that you cannot put more than 2 embryos unless there is special situation wherein
No,
three
it's for
very
day
special
three
situation.
embryos, it is
Three
three
is out
embryos.
of the
For day
question.
five.
Yeah. And next is when there are a lot of
Sir,
papers
sir,
who
for
suggest.
day three, sorry, for day three, it is three embryos. For day five, it is two embryos. And for
Yeah, two
PGTA tested,
embryos.
it's one embryo.
Yeah,
I think we should
no,
all
ERT
move to
Act
day
doesn't
5.
say PGT tested 1 embryo. It says 2 embryos the
Yeah.
maximum. If possible, maximum 2 embryos. Very special situations, 3 embryos. ERT Act specifically doesn't say about PGT tested. So that's a wrong statement. So next, so when you are putting 2 embryos, so there have been papers which say that when you are putting 2 embryos versus 1 embryos in another cycle, like to 1 embryo, if you divide into 2 cycles, the rate of pregnancy is higher when 2 embryos, means 1 embryo in 1 cycle. If they are taken 2 cycles, the pregnancy rates are higher compared to putting 2 embryos in a single cycle. So single embryo transfer not only is safe, but also if a cumulative pregnancy rate is seen, it has a higher cumulative pregnancy rate.
Okay, great. Yeah, so I'm glad that you all agree about the single embryo transfer mostly. If they're two grade B embryos, probably you'll be doing a double embryo transfer, right? Something like that.
Yeah, most of the times it's a single or double.
Yeah.
You discuss with the
Yeah.
patient and take patient's
Sure,
consensus
sure.
and make a decision.
In fact,
Right.
putting
So,
a poor
yeah.
embryo, quality embryo with a good embryo reduces the success rate. So we'd rather just put in the good one.
Right, true. So I think we will go on to obviously the risks associated with twins, we all know about it. I would particularly want to ask about the evidence for the use of progesterone and the evidence for cervical cerclage. Dr.
Madhu?
Dr. Madhu, maybe, yeah, why not?
Yeah, ma'am. So, actually speaking, cervical encirclage we don't do it.
We'll start with progesterone. We'll start with progesterone, please.
Yeah, so progesterones is mainly indicated in patients who have previous histories or who are twin pregnancies, who have previous history of missed abortions or miscarriages. It is not routinely recommended, but everybody has their own protocols and everybody prefers to give progesterone because it's an artificially stimulated cycle, so we prefer giving it. Although the studies suggest that there isn't much of a difference, honestly, but we all prefer doing it. Regarding
Dr. Madhu, we're talking about progesterone to prevent preterm delivery in twin pregnancies, not the luteal phase support.
Yeah, okay, ma'am. Sorry, sorry, there was a bit of confusion regarding that. Yeah, so basically regarding preterm deliveries also, because there is already a placenta which has been supporting the pregnancy, there isn't much of a role of progesterone. That is what we've been taught, honestly. So, but patients with a short cervix might benefit from it.
Yeah, sorry, I was muted. Yes.
Yeah,
No, that's right. I mean, that's what
yeah.
the progesterone, the trial, the Cochrane review, they all say that there's no, significantly reduction in the preterm birth. But as you rightly said, with a short cervix, progesterone may reduce preterm birth, especially in twin pregnancies, similar to singleton pregnancies. So there's no difference in the way you manage twins as compared to singleton. But yes, I certainly do something called the serial cervical length monitoring in all IVF pregnancies, especially the ones who had a hysteroscopy or multiple hysteroscopies or something like that, which may have impacted the elasticity of the cervix. So yeah, the current guidelines recommend progesterone only if there is a short cervix or other high risk factors in twins as well. So it's not universally recommended. Now, coming to the benefit of prophylactic cerclage in twin pregnancies, and this is something that fertility specialists who refer to me and I always have a bit of a tussle about. So I'm sure you all want to protect the IVF pregnancy as much as possible and would recommend cerclage to the lady who's being referred to the obstetrician. But once again, I'm probably of the school of thought that it may even cause harm and increase risk of preterm birth. So instead, I think serial cervical length monitoring would be a good choice. Go ahead. Anybody can comment on this.
Yeah, ma'am, we follow the
Dr.
same.
Aruna, in case if
Sorry.
the patient has
Who's-
had any uterine abnormalities prior to
Sorry,
IVF,
who's this? Yeah.
Dr. Shilpa here.
Yeah. Go ahead. Yeah.
Yeah, if there is any history of any septal resection or if
Yes.
there was any bicornuate uterus, in this condition we can do a prophylactic cerclage, or otherwise in the anomaly scan when we see a short cervix, there we can do a cerclage, but as such prophylactic cerclage for twins is not indicated.
Yeah, so that's right. That's why I put this
So-
slide about septal resection or submucous myomectomies, etc., where you have to dilate the cervix to a large, to a significant extent, and that would sort of injure the cervical elasticity and the muscle. In such situations, again, kind of a surveillance of the cervix and they definitely warrant a cervical surveillance, and then accordingly, place the suture. Instead of jeopardizing the pristine uterus with a stitch, having to prick the cervix several times to get get the Merceline tape in. So yeah, that's obstetrician's point of view. All right, so we'll go on to Dr. Shilpa and Dr. Ravi. Dr. Shilpa, you can't put your video on, is it? Is that possible? Dr. Archana, are you there? Yeah, hello. Yeah.
So let's have a
Yes.
discussion on the
Go ahead.
30-year-old woman with triplet pregnancy post IVF confirmed on a 7-week scan. So what are the particular consideration you want to do in this triplet pregnancy? What advice would you like to sell? What is the risks?
Yeah,
Archana?
Sorry, sir. Please.
Dr. Archana is there? Archana Dadena?
Yes, sir.
Yeah, please.
So these patients are for high risk for preterm birth and maternal complications. So first thing we should consider is selective fetal reduction.
So I think in these cases, now what is more important is we tell them that there is a very good chance of a spontaneous reduction happening before you NT scan. There is a very spontaneous, there is a good chance, we've had a lot of
Absolutely
patients
right.
where,
Yeah.
yeah. So you just wait out till and you explain it to them, the moment you kind of see a multiple pregnancy, even with respect to twins also, that's something we tell them that there is a very good chance till your NT is over, we won't be able to kind of say in case of both the pregnancies will continue or not. Once your NT is done and once the NT is evaluated, then most of the times what we do is when we send the patients for the first trimester screening, at the same setting, we kind of advise them to kind of go ahead and get the fetal reduction, because I think that 12 to 13 weeks of window is a good time for us to kind of reduce the pregnancy without increasing the risk of miscarriage. But yes, if it is a twins, then we would if it is a triplet, we would always prefer reducing it to a twin rather than a singleton altogether. But of course, it's always the patient decision. And in fact, we've had patients who've conceived through IVF, had triplets, and then they wanted to reduce it to singleton because they were concerned with the factor that if it is a twin, people would kind of feel that it is an IVF conception per se. And, because of that social stigma is why they wanted to kind of reduce it from a triplet to a singleton. And, that we still went ahead and did that. But yeah, essentially, I think it should be
Interesting.
counsel for them. Yeah.
Dr. Madhushri, are you trying to
Yes,
speak?
ma'am. Yeah, am I audible? Am I audible?
Yes,
Yeah.
audible.
So I just want to add one thing, like while explaining them to go for reduction for triplets, while we are advising them to go for reductions, we have to also explain them the chance of miscarriage after the procedure as well. So we have to be sure that they know what are the risks associated with the procedure before they actually go ahead with the reduction. That is the only point that I wanted to add.
Absolutely. Yeah, that is very important. So counseling makes a very important aspect, especially sitting together with a fetal medicine specialist And it would be nice to have the fertility specialist, fetal medicine, and obstetrician sitting together to make this decision. And those who are blessed with having a comprehensive unit can certainly do that in a better manner. But as you rightly said, the selection of the fetuses to be reduced will also depend on risk of an aneuploidy, the accessibility with, for KCL injection and fetal anomalies. So waiting till the NT scan, waiting until we know what the NIPT shows, etc., makes a huge difference. And also the chorionicity is an important aspect of triplet pregnancies.
Dr. Aruna, regarding this, I wanted to say we had a 43-year-old lady who went for a donor cycle. We transferred 2 embryos, blastocyst, according to her age, and she had a triplets. So one was a mono amniotic. So that time the decision was given to her. So from triplets to it was done to single.
Yes,
Because
that's
these
a
2
very
twins
important.
plus 1 more baby was separate.
Yeah, absolutely. So that makes sense. But many a times the placement, or rather the location of the twins and the singleton, are always a little critical. Like, the twins may be on the top and the singleton may be in the near the cervix. And these are the situations where they're very tricky, and you've
Tricky
got to
about the
explain to
things.
them.
Yes.
Very recently, about 2 weeks ago, I've had to sit with that lady, with the fertility specialist and the fetal medicine specialist, on 3 different sittings before we could plan all this. Luckily, touchwood, she's doing well with the singleton now. Yeah, so very important. So coming on, Dr. Mahesh, would you like to go ahead with this case?
Yeah.
And
Case 4, see, the patient profile is 32-year-old woman. She is 18 weeks pregnancy with a short cervix of just 2.2 centimeters. Previous cystoscopic septal resection was done, and now it was a frozen embryo transfer done for her. And now outline the antenatal consideration and modification in antenatal care. So what you would like to do, what risks you would like to explain. Now we stand at 2.2 with 18 weeks. Can we do something now? So Dr. Shobha?
Yes, sir. So she's a patient who will need encerclage. Actually, I think maybe after NT only we should have planned encerclage for her. I would also like to know what was the cervical length during that time. If it was less than 2.5, it would have been better to put cerclage then only.
no, it was not less than 2.5. At that time, it was 3.2.
Okay. But because she has undergone a septal dissection, I think we should have counseled her regarding chances of preterm labor and chances of abortion, and put her on the progesterones, vaginal progesterone preferably,
And now, when
cervical.
you want to put a cervical encerclage, you prefer a vaginal route or a laparoscopic and abdominal encerclage?
Abdominal route is better, I think, sir, for this patient.
Okay.
Why would you say so? Why would you say so, Dr. Shobha?
Sir, there was no other uterine anomaly, only in the because she had a septum, maybe there will be some problem with the cervix, compared to the usual cervices. Those with uterine anomalies, those cervix will be little weaker. That's what I have noticed. So usually when you do a McDonald's, they do not do well, madam. Maybe a Shirodkars would be better for this patient than a McDonald.
Agree. A high McDonald's or a Shirodkar probably.
Shirodkars is a better
Not
choice.
necessarily an abdominal cerclage, probably, but yeah. All right.
Laparoscopically, you can do.
Yes, madam.
Yeah, we can do. Compare, I mean, with all the challenges of an 18-week pregnancy and also the risks of preterm. Again, uterus being irritated by the anesthesia, by the handling, etc. But again, that's a whole lot of counseling. But my experience, a good Shirodkar or a highly
Shirodkars
placed
is a better choice
McDonald's.
now. Maybe if it fails, then we should think of abdominal.
Also, the kind of material that you use for a cervical encerclage makes a huge difference.
Yeah,
I've seen
Mersil
putting it with
tape would be better.
Yeah, Merceline tape really works well. And touchwood, I've had very, very few failures with Merceline tape, touchwood. So yeah, now we'll talk a little bit about, because this is something that is an overlap between obstetrics and fetal medicine and fertility. I really would like to talk about the various, let's say, pre-primary, primary, and secondary, and tertiary, and even quaternary the prevention of preterm labor. So when you talk about pre-primary prevention, what are we talking about, Dr. Shilpa? Or Dr. Archana Dwivedi, maybe? This is pre-primary. That is even before they start the IVF pregnancy.
Pregnancy, as we discussed at the start
Yeah.
of the panel, this will be a very high risk case, so we have to take all the precautions. Prenatal, as you already have told, that take care of the comorbidities, give antioxidants, folic acid, healthy weight, nutrition, diet, lifestyle modification. There should always be taking a vaginal swab culture to avoid any infections in the later on stages. And if she's exposed to like job profile, the environmental toxins, most of the people are working in the chemical industries and all, she should be told about the risk involved.
Yeah.
And
Right.
I think if there is any uterine abnormality or any issues
Yeah.
at point of
So
time.
here I have a question, regarding uterine anomalies. Dr. Aviva, how do you, if there is a suspicion of a biconjugate or a very sort of let's say short septum, etc., what is your mode of imaging? What's your imaging mode? Is it like a 3D TVS or it's an MRI? How do
Yes.
you normally sort of screen your?
A good
3D TVS.
Yeah, a TVS, a good 3D or a 4D will pick up the septum. Then we, of course, do the hysteroscopy and decide with that. Sometimes these, very rarely do we always insist on an MRI or something. Most of the time, they are picked up on a good ultrasound.
Yeah, and what would be the kind of septum that you would want to resect on hysteroscopy?
Ideally, any septum should be resected because it's known that it can cause recurrent implantation failure, recurrent pregnancy losses. So septal resection most of the time is done hysteroscopically, and then we do the embryo transfer post that.
Sure. Okay. Thank you.
Dr. Aruna, you're on mute. Kindly unmute yourself.
I'm so sorry, Dr. Archana, Dr. Shobha, Dr. Shilpa, any one of you. What are the primary prevention strategies during pregnancy before the signs of preterm labor? What would you like to do?
The serial ultrasound for the monitoring of the cervical length has to be done. Anytime if you find there is a short cervix less than 2.5 centimeters, then cervical cerclage is indicated. And the lifestyle modification has to be told to them if there is any previous history of preterm labor or short cervix, that to avoid a heavy physical work or strenuous activities, and consider supplementation of progesterone, vaginal progesterone.
What's your particular preference? Progesterone.
Vaginal route is better because of the bioavailability.
And which one? What's the
Micronized
dose?
progesterone,
Dose?
400 mg BD dose.
600 should be ideal. I think that is a better, 600 to 800 is the ideal dose.
In a case of, don't you think that's a very high dose?
No,
In a
no.
case of what? In a case of prevention of preterm delivery?
See, either give it
in an IVF
dose
pregnancy?
or don't give it. A subclinical dose is not going to help you. It is not luteal phase defect. We are trying to prevent the preterm labor.
Yeah, but she's not, I mean, she's not having any risk factors as such. It's just an IVF pregnancy. Would you want to give 600 to 800? Isn't that too much of a dose?
I think most of us use that dose. It's 400 for vaginally for IVF pregnancy.
400, right? 400.
400 BD, we do use that dose most of the time.
All right. Okay. Right. Yeah. And omega-3, I think that's a very important, it does have benefit in preventing preterm delivery. So omega-3 supplementation is something that we would all want to do. Now coming to secondary prevention, that is early detection and intervention. When you want to detect early signs of preterm labor and intervene to delay delivery, what are the interventions here? Dr. Shobha? Am I missing anybody? I'm just Dr. Shobha, Dr. Shilpa.
Dr. Ruta is there?
Dr. Yeah, I.
Dr. Ruta?
Yeah, I'm
Dr.
listening. Dr. Ruta is there. She's there.
Is she there, Dr. Ruta? I
Yeah,
can't see you.
I'm fetal medicine
Oh, there
specialist.
you are. Dr. Ruta, please take this question. So
Yeah,
sorry.
actually, I'm fetal medicine specialist, and thank you very much for
Oh,
including me in the
look,
panel.
we didn't know that.
I'm
I'm so
listening
sorry.
silently to all.
Yeah, so this
So
is
for
something we
me,
can take.
early detection would be, as a fetal medicine specialist, will be cervical length monitoring, and that has to be serial cervical length monitoring. For me, 16 weeks to 24 weeks is the main target area for early detection of preterm labor, and which would go on. And I think the medicine and all part, I think another end when contain. For me, cervical and surveillance from 16 to 24 weeks.
Dr. Ruta, I'm very happy that you're here. I was looking for a fetal medicine specialist in this panel. And I mean, I know that still cervical length monitoring is an important aspect of your daily work. So I just wanted you to tell us 4, important aspects of the measurement in terms of empty bladder, full bladder, angle, and elasticity. And now that we have some advanced scans machines, we can even actually get to know the elasticity as well. So would you mind educating us about that?
Certainly. Actually,
Elastography.
for me, I have no idea about elastography. I prefer transvaginal or basic measurement of cervical length. And I think method is very important. As you said, empty bladder is very important thing to do. And the method of measuring is very important. Always you should know from internal os to external os, where to start and where to end, and the tracing method. And you always take 3 measurements. Never depend on the one single measurement and label that it is a short cervix. Never do that. Take at least 3 measurements and then label as a short cervix. As we know, the cutoff is 2.5 millimeter. Elastography, I am not aware of it, and I don't.
Right. Yeah.
I
so
do
I
basic
think
cervical length measurements
Yeah.
by transvaginal.
So there are a lot of advances in cervical length monitoring, including elastography and the uterocervical angle. The uterocervical angle and the elastography. And that actually is showing a lot of promise in detecting those who require earlier intervention. Also, the fetal fibronectin testing, wherein it's a little kit. We take the discharge from the posterior fornix. There's a kit. We wait for the, it's like a UV pregnancy test kit where it says it's, positive or negative, and it's in a highly sensitive test because it has a high negative predictive value. If you have a negative test, you're very convinced that this lady is not going to go into preterm labor in the next 7 to 14 days. Whereas if it is positive, she's likely to have a delivery within 7 to 14 days. And this is the kind of these are the kind of women who require more surveillance, steroids, probably magnesium sulfate, and a neonatal review. So I think some of these are important for us to know. And of course, antibiotics for bacterial vaginosis and for recurrent UTI make a huge difference to reducing our preterm labors. Now, coming to tertiary prevention, tertiary prevention is already she is in labor. I mean, in preterm labor, she's already showing signs of preterm labor. Who would like to take this question about tertiary prevention of preterm labor?
Tocolysis.
Yeah.
So this
now we don't use Duvadilan and things like that. We use atosiban, nifedipine even for acute tocolysis. Nifedipine works beautifully well. Atosiban, indomethacin only in cases of very extreme polyhydramnios, but obviously trying to get off the. Sorry, I think there's a background noise on my side. Get off the Duvadilans and all that. So because they do cause a lot of maternal complications. Go ahead.
Tocolysis and see if there is any infection. Take a vaginal swab. Then we have to give steroids and magnesium sulfate if we feel the patient is going into labor. And if there is any
steroids before what gestation and magnesium sulfate before what gestation, Dr. Shobha?
Pardon?
Steroids at what before what gestational age, and the magnesium sulfate at what gestational age?
Usually after 28 weeks to up to 35 weeks, I give steroids.
Yeah, absolutely. 34 plus 5.
Magnesium sulfate before 34 weeks, 28 to 34 weeks.
The evidence says 31, 32 weeks magnesium sulfate, and for steroids it's 34 weeks. Yeah. So, but then it's a the gray zone at that point of time. Lovely.
Then do cultures, like if we are suspecting urinary infection, do a urinary culture, and then if there is vaginal infection, do a vaginal culture. Then add antibiotics accordingly. And good hydration, tender loving care matters a lot in these patients. And if there are a lot of family matters, emotional matters, this is very important.
Yeah, absolutely. Yeah, you're right. Prevention of domestic violence also.
Yeah.
And
Good
stress.
hydration also helps in these patients.
Yeah. So just one last slide about quaternary prevention, that is avoidance of over-medicalization and harm. Because our aim is primum non nocere, don't do any harm. So avoid routine tocolysis in cases where delivery is inevitable, or or avoid unnecessary hospitalization and bed rest without clear indication. A careful use of interventions, judicious use of antibiotics, and judicious use of all the armamentarium that we have. So that's quaternary prevention. Dr. Mahesh, would you like to take this case of how many more minutes can we just quickly wrap up with preeclampsia and gestational diabetes or paternal aging? What shall we take?
Yeah, I think the paternal aging will finish it off.
Yes, yes. We'll go ahead with this case.
Yeah. So she's a 35-year-old woman with a 50-year-old partner undergoing IVF. What are particular challenges that you will see in this case, Dr. Shilpa?
As we all know that as the maternal age increases after 35, so there is an increased risk of chromosomal abnormalities. But nowadays, as the paternal age also increases, but according to many studies, the age is not fixed. In some studies, they have given above 40 years, or some studies they have given is above 45 years of age. There is increased risk of epigenetic changes. So these may lead to the chromosomal abnormalities in the fetus. And the sperm quality also goes on decreasing. Either the maybe a count, motility, morphology, all may be affected. And the DNA fragmentation index also increases with the aging. And the offspring may have an increased risk of neurodevelopmental disorders, like it may be autistic disorders or schizophrenia. And there is an increased risk of childhood cancers like leukemia. So these are the association with the advanced paternal age.
Yes, yes. So I think with this, Dr. Aruna, shall we?
Absolutely. Do you do anything differently with an advanced paternal age? All the fertility specialists?
So especially when the male partner is having the above 40 years, then DNA fragmentation testing will be done, and depending on that we decide what mode of fertilization we should use. Either we can use the direct ejaculate sperms, or if the DFI is very high, we can give antioxidants for 3 months and then do a semen analysis. If it is better DFI, then go with the ejaculate sample. If not, we can go with a teaser sample.
Right. Do any one of you use IMSI or this one, a Pixie?
Yes, we use. If the DFI is between 20 to 30, we still go with a sperm sorter with Pixie procedure. If it is above 30, then directly with the teaser sample.
Right. Okay. Wonderful. So I think the first trimester screening, we kind of covered it in the previous thing. So thank you very much indeed. I think we've covered a very wide, diverse cases. So we all know that we have to do genetic counseling for all our IVF patients. We all know that if PGT is performed, even if the PGT is performed, we still have to do prenatal first trimester screening. Placental localization, surveillance is important. Fetal echocardiography, which I think somebody mentioned initially itself, should be offered to all pregnancies achieved with ICSI, especially. Assessment of the fetal growth, definitely performed, probably in some cases throughout, but definitely in the third trimester. Weekly antenatal surveillance by 36 weeks because of higher risk of stillbirth. Genetic counseling, as we said, pre-genetic prenatal counseling, multifetal pregnancy reduction in cases of higher order pregnancies. Fetal echocardiography, then visualization of the cervix between 18 and 22 weeks, and of course, serial cervical surveillance, especially if she's had any hysteroscopic procedures. Do not recommend low dose aspirin, especially if it's an IVF pregnancy without the risk of preeclampsia. and um, timing of delivery. Now, there is no particular evidence to say that we have to induce them at 39 weeks unless there are obstetric sort of indications. So if everything is okay, we can go up to 40 weeks. But again, that's a very important shared decision making that we must have. And thank you, Dr. Mahesh. And these are our references. Dr. Mahesh is an ours. And thank you very much, panelists. And thank you once again, Dr. Archana, for this wonderful opportunity. I think the journey of creating life through IVF is not just a medical feat, but a testament to hope, collaboration, and the power of multidisciplinary care to turn dreams into reality. Thank you very much for the opportunity.
Thank you. Thank you
Thank you
all
very
the
much, Dr.
panelists.
Aruna and
Yeah.
Dr. Mahesh for really steering the panel so beautiful. And all the panelists, Dr. Archana, Dr. Madhushri, Dr. Ruta, Dr. Apurva, Dr. Shilpa. I think I have spoken to most of you when I was in Bengaluru. And it was like really all the points you have really brought out so well. All the key points were covered as far as the risk associated with IVF pregnancy and multidisciplinary approach. And what I always say, what happens, just one word, what happens when a patient comes to you in India, even still the IVF is considered as a not something you will tell others. Patient will not tell that she has conceived with IVF, and especially with the donor cycle, or she has been prepared. So you as an IVF person, you are doing, just put a red dot, because patient may not reveal that she had a pregnancy with IVF, and then she has all the complications of pregnancy. So it is good to know many. Nowadays it is open, like people do say that I have conceived with IVF, but many a times they may not say. So it's important that we put some mark somewhere, or there is to be communication between the IVF provider and the obstetrician, or they should ask when your care was taken before. You need not document it in the notes, but it should be notified to the person who is taking care, even in the periphery or in the primary or secondary or tertiary level.
Sorry,
So
Dr. Archana, may I request all the panelists to keep the videos on for a screenshot maybe? Would
Yes.
somebody be able to take the screenshot?
Yes,
Who
we
could
can
help?
take,
Shruti, could
just
you?
come.
Shruti, would you mind taking the screenshot, please?
Yes, ma'am, I'll take it. Just
Dr. Aviva, Dr. Shobha, please,
Yeah.
thank you. You've spent time with us. Dr. Aviva, please put on your, and also Dr. Archana, that they never.
I'm here. I think Dr. Archana from Baroda, she's not seen.
Dr. Aviva, are you there? You left. Okay.
Dr. Archana Basir, ma'am, I'd like to request you to adjust your frame for the photograph.
Is it okay now?
Yeah, it's okay.
I think my head was not.
Yeah.
Somebody told me before also.
No issues.
Thank you very much.
Thank you.
Thank you. And please post this picture on our group. Okay, Shruti?
Yes, ma'am.
Thank you. Thank you.
Thank you.
For giving us the platform.
Yeah.
Really enjoyed. I
I'm-
think it's a really good way of learning from each other. So very happy.
Ma'am, formally, with your permission, may I now proceed for the, to deliver vote of thanks on behalf
Oh
of
yeah, of
Clinical
course,
Science?
Please, please.
So yes. So
Mr.
formally,
Chaudhary.
hi, good evening, everyone. This is Rishikesh Chaudhary, and I'm GPM from UNS Marketing, who are the brand lead for Coenzyme Q10 300, that is CoQ 300. On behalf of Universal NutriScience, I would like to take this opportunity to extend my heartfelt gratitude to all our eminent speakers, chairpersons, and panelists for sharing the valuable insights and making today's sessions truly enriching, right? And a very warm and very special thanks for Dr. Archana Basir, Madam, for being the program director for Fertilogix and the entire MPSR team, especially Dr. Rudri, Dr. Kalyani, Dr. Shruti Shetty, for their continued guidance and enthusiastic support in this collaborative initiative called Fertilogix. I would also like to thank Dr. Shruti Patwal for her relentless efforts behind the scene and extend my sincere thanks to Dr. Manish, Head of Medical Affairs at UNS, as well as our marketing team, Pallavi More Madam and Nikhil Mehra sir, for their commitment toward this event. Finally, I thank all the participants for their valuable time and the presence. We look forward to see you again in our upcoming Fertilogix webinar 4, which is scheduled very nearby next month. So with that, I conclude my word of thanks. And so thank you everyone, and have a great evening ahead. Thank you. Thank you, everyone.
Thank you so much. Thank you so much to all the
Thank you
doctors.
so much, ma'am.
Thank you.
Thank you so much.
Thank you,
Thank you, ma'am.
everyone.